Everyone. Hi, Ken. Good morning, everyone. Yay, there we go. You're probably only halfway into your first cup of coffee. I really am surprised to see this many people this early on the last day. You have a problem. Now, the first of the 12 steps, is admitting that you have a problem. I was expecting to speak to a whole bunch of people in the room this morning. Still in their underwear watching this live stream. So it's nice to see you guys dressed in here. One of the things I just wanted to mention before I started the official thing, that's why I'm not standing up in the box and being recorded, is that coming to these courses, even though, it's preparing for a high-pressure exam, from a faculty standpoint, it is absolute joy because you get 300, 400, 500 people in a room that have 10, 20, 30, 40 years of experience. And we've studied for these lectures, we've refined them, we've prepared them. And there's always somebody in the room who knows just a little more, right? It's amazing. There's always someone out there who's going to be more of an expert. And I learn as a faculty member every single course from that. And so I wanted to thank you for all the information and helping me become a better doctor because of these courses. So thank you very much for helping me provide better care to patients. I really appreciate it. The second thing is I get to see people that I haven't seen in years. And so I don't know where Mercedes is, but she came up to me just before this lecture and we were classmates together. I haven't seen her in years. It's our 25th reunion coming up next year, 25 years since we graduated from medical school, and I'm like, holy smokes, right? Where did that time go? And you know that when it comes to reunions, it's not the years sometimes, it's the miles people have put on, and you get to the reunion and you go, oh, that didn't age well. Dodged a bullet on that one. Mercedes, you look fantastic. I don't know where you are, but you haven't changed at all. I was like, whoa. As soon as she came around the corner, immediately recognized her and went, wow, it's so good to see you. So that was another joy for me this morning. And so I wanted to bring some joy into this whole, I'm studying for an exam. It's hard, it's difficult, it's something, it's a hoop you have to jump through, but it can still be fun and enjoyable. So it's right at 7:30. See, I started right on time. I've got an issue. All right, more than one. So first of all, this is going to be a 75-minute lecture on pediatrics. And we can't obviously cover the breadth of pediatrics in 75 minutes. And that's why through this program, you've received information in other lectures. We're talking about Salter-Harris fractures. We're not going to be talking about that today in this lecture. We've covered it through the orthopedic stuff. But there'll be some spaced repetition because I'll go deeper into HUS during the pediatric lecture. But this is just some core stuff that wasn't covered in the other lectures to put into one box that we're going to call pediatrics. Now, I work at a community hospital. I don't work at a tertiary or quaternary center. I work at a community hospital, and I see everything. I see womb to tomb. I see cradle to grave. So I see children. I'm the ologist in the building, right? I'm the pediatrologist, the orthopathologist, the gynecologist. Everything comes through the emergency department. Who here sees kids? The rest of you are scared, right? Okay, this will hopefully go, oh. That peaceful picture of the middle is how you should feel when seeing children. Don't panic, just deal with the problem. So we're going to start out with a simple concept of, can you treat that child? Do you have consent to treat that child? A little medical legal. And just like adults, if it's life or limb, treat. You don't need consent. Easy. The next thing is, do you have to inform? And different states have different laws regarding whether you have to inform. Almost universally, as far as I know, if you're suspecting child abuse, you have a duty to inform. You can breach confidentiality. And then there are other things like pregnancy, access to mental health, STIs, that are state-to-state dependent. And then the final thing on this first slide on, do you have to consent to treat the minor? Do you have to treat to their parent or care, the person who can provide you consent? You can have something called an emancipated minor. And you can be emancipated as a child and make your own decisions. Now, a lot of this stuff originally came from Hollywood and child actors who wanted to break an association with their parents so they could make their own business decisions. But it also involves health care. And so an emancipated minor can be if you're married. And I just did a Google search, and there are some states where you can get married at age 14, 15, 16. So you could have a 15-year-old who's married. You don't have to ask their parents to consent to treat them. They can consent for themselves. They've been emancipated. Now, another thing is if you're a member of the armed forces, if you can sign up and serve and die for your country, you can decide your own health care, right? The final one's a bit trickier. Now, I usually poll the audience to see if there's a case report. But apparently, if you're a self-supporting child living on your own and not in the basement of my house, I have 3 kids, 2 have moved back in university. If you're emancipated and out there living on your own, you can make your own decisions. I think they should flip that around and say, if you're still 30 and living in your parents' basement, can you make your own decisions? Because your mom's still doing the laundry, right? So that's the emancipated minor thing. All right, let's start with inconsolable crying child. All right, because what do children do? They cry, they eat, they poop, right? They cry, eat, poop, and sleep. That's basically it when they're really little. That's their whole repertoire. So we're going to talk about crying, but crying is a normal behavior, especially if that's the only way you can communicate. I'm hungry, cry. I'm sad, cry. I'm tired, sad. I hurt, cry. This is inconsolable crying. This is crying that you can't settle, that you can't calm down, that you can't soothe. And so inconsolable crying can come from a number of different situations. The first one we put down there is colic, intestinal colic. We have no idea if it's coming from the intestines, but we call it intestinal colic. And this is defined as children inconsolably crying. You can't calm them down for 3 hours a day. Wow. For more than 3 days a week, for 3 weeks. Wow. You can see how exhausting that is. We have 3 children. One of our children had colic, and it is exhausting to have a child that you can't calm down. Now, the presentation is usually they turn into this like screaming devil child, right? Cry, cry, cry. They look like they're in so much pain, and then all of a sudden it's gone. And they're back to being this beautiful child that you brought into this world. And then they start again. So it's colicky in nature and goes back and forth. Usually they pull their knees up, pull their arms up, cry, and then they're fine. Now, it says normal labs and physical exam. We really don't need to do laboratory tests usually on a well-appearing child in between these colicky episodes. It's a diagnosis of exclusion. I've got those red things in there because those are the highlights, but it can be a risk for abuse, right? So if you've got a child that's inconsolably crying and it's going on for hours, days, weeks, potentially months, you can see how that could be a risk factor for abuse. Do you know who the person is most likely to be the abuser? The mother's boyfriend, right? Who's tired of this child crying. So it is a red flag, so provide support there. There is lots of different remedies for inconsolable crying due to intestinal colic, and if there are lots of treatments for something, what does that mean? Nothing works, right? It's almost like if you walk into any pharmacy and you go to the cough aisle, how many bottles of different kinds of cough syrup do you see? Hundreds. Why? Because nothing really works well. Same thing with intestinal colic. All right, so some other causes, trauma, of course, right? Soft tissue and fractures. This is a difficult one to pick up sometimes. Strangulation of a digit, or the penis. You need to look under the diaper, and that's a key concept to this, is you need to look under the diaper. Sometimes you won't find the problem. But you can get a hair tourniquet, right, around the fingers and toes, and so if you have an inconsolable crying child, you actually have to look at all 5 fingers on both sides and all 10 toes, and then take the diaper down to look for that hair tourniquet. Because that mother with the longer hair might be sitting there soothing that child who's inconsolably crying from colic or something, and they get a hair tourniquet, and it can strangulate the digit. Now, the treatment is a depiling agent, or you can take a scalpel, and you need to cut down to the bone, because these thin little things can really cause a ligature there. The only side of that I wouldn't say, to caution you, is if you have a hair tourniquet around the penis, Don't cut down to the bone. That's a separate category of that's called a moil. A circumcision. Not that there's a medical indication for circumcision, but you actually shouldn't cut down. You use a depiling agent to get rid of that hair tourniquet. Infections, of course, can cause this. Again, look under the diaper. Diaper rash. Has anybody ever pulled back the diaper and go, oh my God? You can see why the child's crying, right? Everything from the belt to the thigh is just covered in diaper rash, right? That would be very painful for the child. So look under it. Obviously, a urinary tract infection, other infections. And then we've got a whole bunch of surgical conditions there, incarcerated hernia, testicular torsion. They all say, look under the diaper. Now, intussusception, you're not going to find that on the diaper. You're going to find that on the abdominal exam. But look under the diaper. It's usually omission, not commission. It's because we didn't look. And parents love it. When you bring little Johnny in and you show an interest and you undress them, you give them the show. I remember Rick Bucata teaching me this. They came for the show. That parent and caregiver came for the show. You undress them. You put the stethoscope on. You listen. I don't know what you're thinking about. I don't know, that heart rate's going 120. I really can't see an S2, right? But you've got to show them that you care. So you undress them and check them out. I'm just going to give them a good head-to-toe check. It shouldn't take that long. They're only this big when they're little, right? All right, so rapid breathing in the neonate. That's the inconsolable crying. Now, rapid breathing in the neonate, we need to respect breathing in children because while adults go from cardiac arrest or a cardiac problem, children arrest more often due to respiratory problems. So if you've got a tachypnic child, that is a real concern. And in a neonate under 28 days, lots of things can cause rapid breathing, everything from infection to metabolic abnormalities to heart diseases, and we're going to go through some specific ones, and then neuromuscular diseases as well. So we'll go through some of those specific ones with regards to rapid breathing in the neonate in detail. Vomiting in an infant. When we're talking about vomiting, we're not talking spitting up the towel over the shoulder, pat, 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 oh, watch, it's a llama, it spits. We're talking about where they actually projectile vomit. They vomit aggressively. There are lots of different causes for it. One is what the AAP has rebranded now, abusive head trauma. It used to be called shaken baby syndrome, and you can see how doing this and shaking the child with maybe intestinal colic, and somebody comes up and does this repeatedly, could cause vomiting. Children can vomit because they have an infection, and it doesn't have to be a GI infection. It can be respiratory, it can be a UTI. Some children, just when they get sick, they throw up. Hepatobiliary disease, you should notice jaundice if that's the case. Inborn errors of metabolism. I'm not going to show you all these, like different pathways and stuff. Most inborn errors of metabolism, right, are usually acidotic and hypoglycemic. Acidotic and hypoglycemic. Malrotation of the gut, if you spin your gut around and twist it, it's a conveyor belt, and if everything is still going in, or you're just making saliva and it's got nowhere to go, it has to come out the other end, come back at you. So malrotation of the gut. Pyloric stenosis, you guys should recognize this. This is the child that's doing well as an infant, a neonate, an infant is doing well, and then all of a sudden they start falling off the growth curve, not thriving, losing weight, and you feel that little bump there, and then you get out your bedside ultrasound and you go, aha, pyloric stenosis in this little boy, and it's usually more boys. And then intussusception. Here's a little picture of the malrotation of the gut. The large colon, right? The large bowel is pretty fixed, but that small bowel can twist around on itself, and you can get these malrotations and cause intussusception and various things. Now, from vomiting to diarrhea, again, infectious causes diarrhea. And if we dichotomize it, viruses usually happen in the winter, and in the stomach, in the summer, it's more likely to be bacterial. So in the winter, it classically was rotavirus, but we're vaccinating against that now. We're immunizing children against that, so we're not seeing as much in the winter with rotavirus. Now in the summer with bacterial infections, some key ones are Shigella. And Shigella can cause a toxin that will cause not only bloody diarrhea and fever, but if they're seizing. If you've got a child that presents with diarrhea, fever, the diarrhea is bloody, and they have a seizure, you should be thinking Shigella. So if they gave you a question on the exam and said, you've got this 14-month-old, they're off to the park in the summer and started vomiting, and then all of a sudden got diarrhea, and then had bloody diarrhea, came in with a fever, and they seized in the department. What's the most likely organism? They're trying to tease out, do you know that this is probably Shigella? Salmonella can also give you bloody diarrhea, but doesn't typically give you the seizures. Now, you can get seizures like febrile seizures because both of these conditions have fever, but the classic is Shigella to give you that triad of fever, bloody diarrhea, and seizure. And it's interesting, when you see parents come in, it's changing a bit now that we all have smartphones with cameras on it, but for the longest time, parents used to always come running in, right? They've had the diaper bag and they've got all the setup there, and then they pull out this gift for you to show, right? And it's a little Tickle Me Elmo diaper, right? And they unpack it. The Velcro straps come off, they unfold it, and they show you crap. They want you to see it, and it's like, I've seen crap before, but it's bloody crap. And so they saved it just for you. Now, they want to show you. Now, you can get some information out of that. So if you've got streaking on the outside, right, you're going to be thinking, okay, is this an anal fissure or something like that? If it's all marbled or it's just complete watery blood, that tells you something else. You might be thinking, okay, interception is more likely because there's no well-formed stool there. So there is a reason to show you that. But I must admit, I like it now that everybody has a smartphone and they just take a picture and go like this. I want to show you what the poop looks like. Johnny made boom boom. Take a look, right? All right, so other things that can cause diarrhea: overfeeding, the bambino no eat, abnormalities, anatomical, interception, and again, we will go into interception a little bit more. Inflammatory disorders, malabsorption disorders. You can have the first presentation of an inflammatory bowel disease and Crohn's. Crohn's can be anywhere from the mouth to the anus. Usually presents later in life, sort of teenagers, early 20s, has a bimodal distribution, then up into the 50s. Immunodeficiencies. Oh, and then there's the iatrogenic ones. We gave it to them. It's called clavulin, right? Amoxicillin plus diarrhea. Antibiotics associated one. And then secondary lactate deficiency as well. And so you get this stuff, this lactate fermenting in your gut, and it gives you a diarrhea. Blood in the infant's stool. The leading cause is actually allergic colitis due to cow's milk or soy intolerance. But again, like I said, if you look at the stool, you could see anal fissures for the streaking on the outside, and then you examine the child. They could be temporarily lactose intolerant. Interception is the woot, woot, don't want to miss that one, right? Salmonella or Shigella, right, especially in the summer. And remember, Shigella seizures. And then there's some other theories there. If you have one bloody bowel movement as a child, you get a mulligan, you can write that off if the child looks well. If the child doesn't look well, you're not saying, oh, it's okay. But if the child looks well, they can have a bloody diarrhea bowel movement. That's okay, but not persistent. This one is serious, so you don't write this off. This is necrotizing enteritis. And this happens usually in the first week of life. And we're not sure why it happens, but they desquamate and they just slough off their bowel, their internal bowel wall. And they just necrotize it, and it is a surgical emergency. This is an admission, antibiotics, and see a surgeon. Really high mortality rate. About a quarter of these infants, these neonates, will die because it's usually, again, in the first 28 days of life, usually within the first week. We don't know what causes it. We, of course, say maybe there's a viral component, it's idiopathic. There are things that are associated with the increased risk of having that. Prematurity is one of them. And so if they give you a case to say we have a premature child that was born at 34 weeks, presents on the 7th day and has this bloody diarrhea and looks unwell, they're trying to tell you that this is necrotizing enteritis, and they want you to recognize that that is an emergency for an admission, surgical consult, and broad-spectrum antibiotics. The imaging test looks like this. Now, when you see this image, it's like, well, isn't it just out of focus? But that's the point. It looks out of focus because where the two bowels sort of slink past each other, you get this fuzziness, this thickness and it's hard to see. It doesn't have clear defined lines. You don't see the Hofstra lines. And so if they give you something like that, it's not a bad reprint. It's not they print it, the computer's fuzzy. You can't sit there and go like this to make it bigger. It's actually they're trying to tell you that the bowel wall is inflamed and they're suffering from necrotizing enteritis or enterocolitis. All right, so neonatal jaundice. They're usually trying to pick up the serious conditions. They want you to know that so you don't miss serious life-threatening stuff. And they also want to talk about the most common things. And the most common cause of readmission for a neonate, in other words, in the first 28 days of life, after birth, the most common cause for readmission to hospital is neonatal jaundice. Most of it's physiologic jaundice. It's just due to hemolysis from the red blood cells, and it's fine. This too shall pass. It usually peaks in the first couple of days of life and then fades, right? We've all seen that. Sepsis-related jaundice, if the child looks sick, they look septic, that's different. That's not neonatal jaundice coming from a physiologic reason. And then there's breast milk jaundice as well. And if you want to figure out how to tell the difference between the two, the physiologic jaundice, the child looks well, they were just delivered, and it's 2 to 3 days out, maybe waiting for the breastfeeding milk to come in, those types of things. The child looks at jaundice, they look well, they get better. Sepsis, they look sick, and it can happen at any time. Breast milk jaundice usually happens at the 2 to 3 week mark. The 2 to 3 week mark, and it's due to some of the enzymes in the milk that's preventing the child from processing all that red blood cells, and they get jaundice, and the treatment is just switching from breast milk to bottle milk, and it goes away. Now, the AAP has some guidelines with regards to when you start light therapy. I have to admit, I do not memorize these. If they come in, I look it up. But the real key in big, red, and bold there is if you have direct, conjugated, it's gone through the liver, and now you have high bilirubin, but it's conjugated, it's gone through the liver, you have an outflow obstruction. This is serious. Your body's going to continue to process all of that and continue to increase the bilirubin, and that's going to lead to worsening jaundice because you have an outflow obstruction of some kind in the biliary tree, and that needs to be addressed surgically because it can become a neurotoxin. And so that's the red flag. If you have conjugated, okay, conjugated or direct high bili. Then intussusception. Now, intussusception is the most common cause of a bowel obstruction, right, in early months to years of child's life, and it's the second most common reason they go for an acute abdominal surgery after appendicitis. And where does it hit? The right lower quadrant. And so usually. So when I see a child, right, who's complaining of abdominal pain, everybody's thinking about appendicitis because we know that. So I'm always thinking of, could this be intussusception? And I'm feeling that right lower quadrant because you get this cylindrical mass up in the right lower quadrant. And because you get peristalsis every 20 minutes or so, the child will look like intestinal colic where they'll get really a lot of pain and be upset, and then they're calm and fine in between attacks, but you'll feel a mass on physical exam. And I'm always thinking, could this be intussusception? Because that's the one I'm going to miss. I'm not going to miss the appendicitis because everybody's thinking, oh, could it be Johnny's appendix, right? So you're looking for that. Ultrasound is the best, I guess, diagnostic modality to identify this. So I've got a picture of a CT scan. Yep. So I've done that 3 times now, right? There it is. Yep. It's got a positive arrow sign, so that always helps me. But ultrasound is the way to go with this, and especially with bedside ultrasound. This is one of the easy exams to do. The children are usually thin, right? They don't have a lot of adipose tissue, and you can get there and examine. It's not a big space to examine as well, and you're usually up and down that right ascending colon looking for a specific sign. It talks about the sudden pain and the relief between things and this vertical oriented mass. So there's the CT scan. Okay, fine, it's got a positive arrow sign. But there is the ultrasound. Can you guys see that, though? You don't even need an arrow, do you? Now, people refer to this as the Cinnabon sign or Cinnabon sign. You know, I don't think that looks that sweet. I call it the radar sign. And if I see that, it looks like a radar screen to me, and I'm like, woot, 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 intussusception until I prove otherwise. especially if you've got that child. It's in the right age category, 2 years old, previously doing well, pain here, I feel a mass, they're vomiting, it may have bloody diarrhea, but that's a late finding. It'd be nice to diagnose it before then. And I put on my ultrasound probe and I see a radar sign, my radar is going off, and that's a surgical referral. All right, that's it for that section. The next is on bruise, or bruise, depending on what you want to pronounce the E or not. So bruise. So we're going to go through bruise. Now, if you've been writing this exam every 10 years, the terminology sometimes switches. And so since the last exam, this one has switched. In 2016, the AAP changed the name from ALTI to, I guess we should just call it BRUI if it's ALTI, BRUI. So they changed it from ALTI to BRUI. They rebranded it, right? It's the same condition. So what does ALTI stand for, right? Apparent life-threatening event. So how do you think that went over? You know, with the parents coming in, oh my God, they turned blue and stopped bleeding, and you go, yeah, I've checked Sally out. Apparently it was just a life-threatening event. You can go home now. They're like, can I see a real doctor? Right? And so, you know, you'd have to tell them the diagnosis. I think they had an ALTI. Oh, what's an ALTI stand for? Well, apparently they had a life-threatening event. Bye-bye now. So they changed it to BRU, and that's a brief, resolved, unexplained event. So it's brief, it's gone. Yeah, we're not sure what it is, but they look fine, as opposed to saying life-threatening in there. So they rebranded it. It's the same thing. So the definition is it's a resolved event. They shouldn't be having it in front of you. The child must be less than 1 year of age, and it must last than 1 minute. And I'm sure, you know, there's no, I'm an EBM guy, there's nobody out there going, all right, and go. Johnny's blue. 48, 49, 50. It's a brew, right? Oh, no, they went 61 seconds, so it's not. You know, it's not that. They just want to say that it's brief. And if you've ever had a child who's had a brew, who's stopped breathing, right? You know, children like neonates and infants can like have 20-second pauses. Try holding your breath for 20 seconds while your newborn doesn't breathe for 20 seconds. And see how long it takes you to freak out. And also time and space become one, right? And it's our perception of time. So they just want to know that it's a brief event. It's not a long-lasting event. And then they have things like, okay, so what was their color? Were they cyanotic or pallor, right? So they have to have that component. Absent, decreased, or irregular breathing. So was it or just slow or absent breathing? Muscle tone. Did they get floppy? So hypotonia, or did they get stiff? Now, if they have a seizure, right, where you get a clonic-tonic seizure, that's not a brief, resolved, unexplained event. You have an explanation if they have a tonic-clonic seizure, all right? Altered level of consciousness is part of it, and no other explanation, and that's the key. So if they have no other explanation, if you have a child who's 4 years old, who has otitis media, and who has a fever and seizes for a febrile seizure, that's not a brew. That's a febrile seizure. It doesn't fit in this box. There's high-risk categories and low-risk categories, and that's how they risk stratify them for management. So for high-risk categories, smaller children, and what I mean by smaller children is they were premature and they're young. So they're under 2 months of age, they were premature, and they had more than one event. You're like, I'm taking more attention, I'm giving more attention to that child. We're doing more of a workup, we're all in on that child, we want to make sure they're okay. But if they're low risk, so they're over 2 months of age, they weren't premature, it's their first brewy, the duration was short. It says that they didn't have CPR applied by a trained medical professional, because we've seen people who've done CPR on people that are awake, right? And so it's not, oh my God, you know, like that's all they know. Stop, drop, and start going, staying alive, and the person's like, I'm alive, all right? And so they say, they make that definition that it has to be a trained person. So if it's a lay person doing CPR, they don't consider that part of that factor in the low-risk category. So for the high risk, like I said, you're all in Vegas, right? Full evaluation, consider admission or observing for a period of time. Now, if they're low risk, though, educate the parents. Tell them about a brew. Do some SDM, that stands for shared decision making. And as a public health measure, talk about CPR. Okay. You may do pertussis testing because, of course, children can cough, 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 whoop, and then look like a brew. You can get an ECG on these children if you'd like, and some monitoring for a brief period of time and reassessment if they're low risk. But you don't have to go CBC lights, BUN, creatinine. You don't have to be all in with all the testing, right? Looking for things, getting an EEG, getting a chest x-ray, doing GERD, home monitoring, right? There was a great Gomer blog. I don't know if you know that. It's sort of like, Gomer blog is like the Onion of political satire, but for medical satire. And they said that they were making a joke about ACOG, the American College of Obstetricians and Gynecologists, were coming out with a new APGAR score. And it was called the APGAR T. And the APGAR T would mean at 1 minute and 5 minutes, they would get a troponin. Just so every child in America could get used to over-testing, right? And so you don't need to do this. If a child has a brew and they're low risk, you don't need a troponin on them. You don't need a D-dimer. You don't need a pro-BNP, all right? You don't need to get viral testing, urinalysis, glucometers, and all this kind of thing. And you don't need to admit them just for observation if they're low risk. All right, so that's the brewy. SIDS is different. It's the most common cause of death after the neonatal period and before 1 year of age. Most common when they're little, 2 to 4 months there. All right, there's some stuff in there with regards to no seasonal peak, increase in certain ethnicities, Native Americans, African Americans. Multiple causes are suspected, which means we don't know what causes this, but there are risk factors, right? There's risk factors associated with this. So if you have a sibling that died of SIDS, that puts you at risk factor. If there's multiple children, if it's a younger mother, if there's drug abuse in the home, all of these things can put you at higher risk, but we still don't know what the cause of SIDS is. The key take-home message about SIDS is that the child is supposed to sleep on their back, right? In this very sterile environment. I've mentioned that we have 3 children. I don't know how they ended up into adulthood, because at that point in time, we had every little beanie baby in their bassinet. We had little pillows everywhere. We had a mobile that could fall down and choke them. I mean, we pretty much did everything you're not supposed to do. What you're supposed to do is have them on their back, not sleep with you in your own bed, not sleep with their siblings in their bed. It's just this environment where they can't get wrapped up in a sheet and stuff like that. Have them lie on their back. That's it. All right, so we're going to move from SIDS to pneumonia. The pneumonia section, lungs are the most common site of infection. So when we talk about infections, we're usually talking, okay, it's going to be airway, right, for infections, or urinary, right, a urinary tract infection. Number 1 is in the respiratory system. And group B strep, group B strep in neonates. So under 28 days, group B strep. Why do we test every pregnant woman for group B strep? Because we're trying to prevent group B strep. Are you getting the message here about group B strep? Got it? Okay. Group B strep. We treat women when they're pregnant for group B strep. All right. So other common causes, H flu, M catarrhalis, chlamydia is down there as well. If they get pneumonia, you should be able to see this child breathing quicker, having a fever, indrawing, accessory muscle use, retraction, decreased appetite. We've just highlighted there in chlamydia that the can be afebrile and tachypnic, but they get this little staccato cough and get conjunctivitis and can be hyperinflated with that, but they're afebrile. And then viral, we're immunizing a lot of these children about RSV. There's all these other viruses that they can get. We've got down there that, things like pertussis and stuff like that. We're seeing now cases of rectal prolapse. So the child coughs so hard, they blow out their back end. So they may come in saying, they've got a cold, but that's not why we're here. And you have to take the diaper off, and you take the diaper off, and they've got a rectal prolapse. If you see rectal prolapse in a child that has some kind of URI symptoms, coughing and things, you should be thinking pertussis, especially in populations that haven't been immunized. And there are out there. One of my favorite t-shirts to wear to medical conferences is I got this wonderful t-shirt. I walked around in Vegas last time I was here, and it says, "Vaccines cause adults," right? It's either a conversation starter or stopper. And those with dyslexia go, "No, it causes autism." Oh, no, okay. So, vaccination history is really important, especially if you see a rectal prolapse. So they can try to throw you and put up a picture of a child's rectum, and it shows rectal prolapse, and they'll say, "What's the most likely organism?" And you're like, "What?" Pertussis is what they're trying to get at. Bronchiolitis in Canada, we're experts at this. We have 2 seasons, August and bronchiolitis. So we have like massive amounts of bronchiolitis. It's supportive management, keep them well hydrated, supplemental oxygen only if they're hypoxic and things like that. It can be associated with some apnea and stuff. There were some really cool experiments that they did up in Canada at the Hospital for Sick Kids, and Rick Bucata says is that down the street from the Hospital for Well Children. But Sick Kids Hospital in Toronto did this really sneaky study where they put on a SAT monitor and they dialed it, they changed it, they dialed it up, and so it would read 3 points higher. Now, I think the exclusion criteria was if the real SAT monitor said they were in their 80s or below, or they didn't get into the study, right? But we know that physicians make decisions based on objective data, like what's their SAT? Oh, they're 99, they can go home, kind of thing. So what they did was they rigged these SAT monitors to read 3 higher sometimes. And so if the child may have had a SAT of 90 and it would read 93. They may have said 92 and it read 95. Right? So there were some children that were more hypoxic than the other children that had the regular SAT monitor. And you were more likely to send those children home. What was the end result? No difference in outcome with bronchiolitis with children that had lower SATs. They got even sneakier. They sent parents home with a SAT monitor that didn't show them what the SAT was, right? It was like a Holter monitor for SATs, right? And there were periods of those children with bronchiolitis, extended periods, minutes, multiple episodes where they were SATing in the 70s, and they did well. Right? So bronchiolitis is about supportive management. Now, if you have a child that's SATing in the 70s or 80s, please go ahead and give them supplemental oxygen and admit them. But these children are really robust with bronchiolitis. Pertussis and whooping cough, so we talked a little bit about that, about the rectal prolapse and stuff. We're seeing more of it due to lack of immunization, and also the immunization isn't great. Right? And what I mean is, like hepatitis B immunization works really well, right? You're up in the high 90s with just the first shot. With pertussis, it doesn't work as well. It's in the 80s for seroconversion, and so you don't have a lot of protection. So we're relying on a lot of herd immunity for that. And of course, if you're under 2 months of age, you haven't been immunized yet. And so now what they're doing is with every pregnant woman, what do they get during their pregnancy? They get pertussis vaccination now. They're getting a tetanus shot with pertussis in it every single pregnancy. So if they have 5 pregnancies in a row, 5 years in a row, every year they're pregnant, they're getting 5 shots every single time they're pregnant, just to protect that unborn child and during their first few months of life with passive immunity from the mother to prevent this. And it's adults that are the reservoir, and it's called the 100-day cough because adults, we've got bigger airways, so we don't go cough, 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 and have the whoop. We just go cough, 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 cough. One of the sure signs that they have pertussis or whooping cough in an adult is you count out how many Z-packs they've had, or Z-packs you call them, sorry, there's my Canadian. How many Z-packs they've had in the last 3 months. If they just keep going back to another doctor and getting another one, or now they're on their 3rd antibiotic and it's a respiratory fluoroquinolone, it's probably pertussis, right? It's going to last 100 days. Complications, mucus plugging, increased thoracic pressure, rectal prolapse, there it is, and a ruptured diaphragm or hernia. So these are life-threatening illnesses in children, especially if they haven't been able to be immunized. Treatment goal is obviously to get herd immunity, and then you treat with antibiotics. All right, so from pertussis to febrile seizure, this can be another fair game question on the exam. Febrile seizures. So a simple febrile seizure, it has to be associated with a fever. If you don't have a fever with a febrile seizure, it's not a febrile seizure. We call that a seizure. All right? It's usually age 6 months to 6 years of age, so that a brief, short, it's not greater than 5 minutes. All right? It's not the classic status epilepticus that's 20 minutes in length or multiple seizures without recovery in between. It's usually less than 5 minutes. It's brief. It doesn't have a big postictal state. You usually don't find another cause for this other than the fact that they have a fever, and they usually have some kind of URI or something like that. It tends to occur in families, so it's about a rule of 1/3. So there's about 1/3 of chance somebody in the family has it. a third chance that they've had a febrile seizure before, and a third chance that they will get another febrile seizure with their next febrile illness. Compare that to a complex seizure, longer than 15 minutes. Oh, that's complex, right? If you've got somebody that's seizing for 15 or 20 minutes, I'm putting that in the status epilepticus category, all right? We're moving on from the benzos to second-line and third-line agents for that. Certainly if they're at the extremes of age, so we shouldn't be seeing febrile seizures in 2-month-old and in 10-year-olds. So if they're outside that 6 months to 6 years of age, that's complex. That needs more attention and more workup as opposed to reassurance. All right, so causes of seizure amenable to a specific treatment. I've seen this, and my father-in-law is a pediatrician. He's the one that clued me in on this. I had a child that had gastroenteritis. So they had nausea and vomiting, nausea and vomiting, nausea and vomiting, and then went to bed. And they slept for, 12 hours. They had this long, prolonged sleep. And then when they got up first thing in the morning, they seized. And I'm like, well, that's weird. And they don't have a fever. Is it gastroenteritis? They didn't have bloody diarrhea. Is it Shigella? What could it be? And then they were so hypoglycemic. It's because some children don't have a lot of glycogen stored, and so their sugar level drops to a point, and all they need is a little sugar. So you give them some 10% dextrose. So we've got to watch that with gastroenteritis in pediatrics. Hyponatremia, so I have given sugar to children that are seizing. I have never given hypertonic saline. Has anybody given hypertonic saline to a seizing child? I've given it to a seasoned adult. Somebody's got a sodium of 111 and they start seizing, they're getting hypertonic saline. But I've never given hypertonic saline to a child. No? Okay. How about hypocalcemia? Haven't seen that, but you give calcium gluconate. Hypomag, give mag sulfate, right? I've given mag sulfate to seizing pregnant women, right? I've given that, and I've given it to Torsade, but I've never given it to a seizing child with hypoglycemia. Now, somebody may have seen INH ingestion, has somebody, in a child that comes in seizing, and there's the anecdote for that. All right, pediatric hydrocephalus. So increased CSF volume, usually associated with increased CSF pressure. There can be a variety of causes for this as well. Congenital intrauterine infections, of course, congenital abnormalities, you can get meningitis, bleeds, but you can have a non-communicating blockage between the ventricles and subarachnoid hemorrhage, and that's got the quote, a failure to communicate. I told you yesterday I give 80s movies to my students so that they get my jokes, and I inherited these slides and this lecture from Rick Bucata when he brought me on faculty, and so this movie's not from the 80s, so I had no idea who this was. No idea. What we got here, boy, is a failure to communicate or something like that. I didn't know what that movie was from. Don't shout it out, because if you know, I'll give you a prize after. I didn't know. I had to watch the movie. It's a great movie, by the way. Excellent movie. Paul Newman, right? At least I know that. Paul Newman. All right? But you can get that. Communicating hydrocephalus, impaired absorption of the CSF, and so that can cause increased pressure. And so here's one of the causes. That you see these large-headed child with big fontanelles, dilated scalp veins going like this, and the head, they call it a crackpot. You tap on the head like that, vomiting, lethargy, but that's sixth nerve palsy. Remember the sixth nerve, and you get that lateral rectus involvement? If you get a tip-off in a case talking about a sixth nerve palsy, they're trying to cue you into this or something like that. All right, and you get the CT scan and you show those increased ventricle sizes. All right, pediatric hydrocephalus. Now the next slide isn't pediatrics. This is, this one is, sorry, the very next one. Pediatric hydrocephalus, always somebody in the audience that's drained one of these shunts, put a needle in there for the child that's come in, always in the audience. I've never done this, but they put a shunt in, they place a shunt in, it can get blocked, and you need to relieve and drain that pressure, so it's simple of just actually aspirating the shunt. Anyways, if you're worried about infection, we have this, if it's dichotomized, if it's early on since you've got the shunt placed in that child, it's more likely to be a skin bacteria, a skin contaminant, something like that. And if it's later, it's the rest of the usual bugs, and they present with meningitis-like symptoms, but it's usually skin flora if it's in the first 6 months after the insertion. Has anybody tapped one of these? Yeah, there's always some. Oh. You have two labs, right? 2 Labradors? Oh, she's not even paying attention anymore. Yes, she has 2 Labradors. She's wearing a beautiful shirt with a chocolate lab on it. All right, idiopathic intracranial hypertension. That's the one I was talking about that's more of an adult situation. It's usually young women, a little bit larger in size. They don't get that increased ventricle size. They're increased in size, but the ventricles aren't increased in size. And they get this opening pressure. Tinnitus, like this is one of those cases when if you were here yesterday for Billy explaining, and they give this reading comprehension test of all these, this long paragraph, and they present a young woman and they say, and she's a little bit overweight and she has some tinnitus, and you're like, what are they getting at? And they're trying to give you some triad to tell you that they have this pseudotumor cerebri, or idiopathic intracranial hypertension. And they talk about visual acuity and tinnitus and those types of things. That's what they're trying to get. You follow them with visual testing to make sure that they're doing okay. And then there's lots of different treatments down there, some of them that we're not going to do, fenestration and lumbar shunts and those types of things. It's a matter of recognizing this condition. But again, it's not so much pediatrics. And there's some pictures of some papilledema for you. You've got the normal retina in the center that's more yellow-orangey color, and then the ones around it, all of those ones around that center one at the bottom, all the ones around that are abnormal, showing that fuzzy haziness and that cup-to-disc ratio for papilledema. Now, you may not have seen it. You go in there with your light, and you're looking in there, and what's the pupil automatically do? And you're sitting there going, okay, so I often, if you're dilating the eyes, you'll see this kind of retina, but unless you're dilating, it'll be difficult to get these kinds of images. So we show you here. All right, moving on to meningitis in children. If they're little children or if they're older children. So in the first 2 months of life, we're worried about where they came from. So again, strep B, right? Strep B, group B strep. Why do we test women for group B strep? Right? Pregnant women for group B strep. It's because we're going to treat this. This can be very serious for the child. So group B strep, meningitis, all right? E. coli, because of the birth canal and where this baby has come from, and then listeria. And listeria is much less common, but ampicillin must be given to the antibiotic treatment regimen to be able to cover listeria. Now, once they get over 2 months, the bugs change, and so we'll see strep pneumo, but also Neisseria meningitis. Now, the highest mortality rate is for the strep pneumo. So strep pneumo is the highest cause of mortality. We've got a red flag there about ceftriaxone in neonates, or calcium-containing IV fluids. I think that's into the weeds maybe a bit. The question can come up, do we give steroids to these children? My typical thing is if I think a child has meningitis, I'm throwing on the antibiotics and I'm letting the admitting team decide on steroids because the data isn't clear. There is specific types of causes of meningitis, like H. flu, that can have better outcomes, but at the time where I'm giving the child the antibiotics, I don't know what bug they have. And the other thing was a subgroup analysis in a Cochrane review saying, children in Western countries with decreased hearing. So a subgroup analysis is hypothesis generating for me, but it's not convincing enough for me to incorporate it into my routine practice. So I don't give steroids to every child with meningitis. I leave it up to the admitting team to decide. And there's just a nice cloudy tap. All right, so now we're going to get into the heart and talk about tetralogy of Fallot. And, yesterday when I was listening to some of the other lecturers going, myasthenia gravis, it's always on there, right? Pediatrics, what's going to be on there of rare conditions that you probably won't see? Tetralogy, right? What else? Kawasaki's, right? They're always got to ask something about Kawasaki's, it seemed. It's sort of the Eaton-Lambert of pediatrics. They ask those questions. So tetralogy is one of the ones they want you to know about. It's the most common cause of a congenital shunt. And this is the one part where I get to throw on my full Canadian accent. You ready for this? On the x-ray, they get a boot-shaped heart. Didn't that sound really Canadian? I could say a boot all day. How's it going? You get decreased pulmonary vasculature markings. And if you understand the anatomy of the 4 different things that are going wrong in this congenital abnormality, you understand why the heart expands to look like a boot and why you don't get vascular markings in the periphery for this condition. They get TET spells where they get, cyanosis, short of breath, upset, syncope, and it increases a right to left shunt, because that's what this is. It's a right to left shunt. Now, if you put blow-by oxygen on, if you understand the anatomy, and we'll show you some pictures, it's not going to work, right? If you have a heart that's taking in blood, right, and you have a garage door open between the right and left ventricle, and you have a cocktail straw to go from the right ventricle to the lungs to get oxygenated, where's the blood going to go? It's going to go through this big garage door over to the left ventricle and get pumped out to the body. And so you're not going to get blood going up and out to the heart, so you're not going to see that vascular markings, right? And if you put blow-by oxygen, you're going to provide more oxygen to blood that's not going to get oxygenated. It's not going to help, right? You try to keep these children relaxed and calm. They bring their knees up to their chest, they snuggle into their caregiver, and that can help because it increases peripheral vascular resistance and can decrease that right to left shunt. And so the knees to the chest position increases that systemic vascular resistance. They've got things like morphine, and again, that's probably just to calm the child down. Bicarb, propranolol. I've never given ketamine to a child for this. I've given ketamine to children all the time, but not for tetralogy. And again, maybe that's just to calm them down. I'm a bit concerned about giving ketamine because it usually increases their blood pressure and increases their heart rate. So there's the anatomy. And if you understand the anatomy, you get this big right ventricle, right? That's number one. Right? You got this garage door for a right to left shunt. So you have this big VSD, and the blood wants to go from the blue side to the red side through that big hole in the heart, that VSD, where that circle is. And then look at that pulmonary artery. Look at how stenotic that is. It's this tight little cocktail straw with an aortic arch going across it, pinching it off even further. So you have those four elements. The blood wants to flow from the right side to the left side and not go out to the lungs to get oxygenated. So providing extra oxygen doesn't help these children. And there's some images. And it's not like they're over-penetrated films. They're not. You just can't see the vascular markings because the vasculature is not engorged in any way. It's not being perfused enough to be picked up on a standard chest x-ray. And you see the heart that looks like a boot. I don't say a boot. All right. HIV in children. There's no way you're going to be HIV in children experts, just like the HIV portion of my hematology lecture. Just a couple of slides here to say that, it is a problem. There is an ascending or a transmission from mother to child that can be prevented using appropriate treatments. If the child does have it, it can cause growth retardation. And remember, it's connected to sexually transmitted infections. The febrile HIV positive child, the most common bacterial pathogens, Pneumocystis jirovecii, is the most common opportunistic infection. Just like adults, you treat them with trimethoprim sulfamethoxazole, or what you guys call Bactrim, steroids as well. And again, they get disproportionately short of breath and fatigued with PJP. All right, Kawasaki's disease. Come on, you've got to expect one of these questions on the exam. So an autoimmune vasculitis of the small and medium blood vessels. And what you have to have is a fever for 5 days. If you don't have a fever for 5 days, you can call it incomplete Kawasaki's. But a fever for 5 days is how you get into the algorithm of, is this Kawasaki's? And they have to have 4 out of the 5 cardinal signs. So it's a measles-like rash, which can be harder now because there is some measles going around. Also, they get conjunctivitis. Measles get conjunctivitis as well. They get the cracked lips and around the mouth, so it's different than the Koplik spots that you see with measles. All right, and then you get the hand and limb swelling, and you can slough off the hands, and then you get lymphadenopathy. So you have to have 4 out of the 5. They don't all present at once, and they don't go, they've got 4 or 5, or they have nothing. It can be a progression over the course of the illness, but they have to have 4 or at least 4 out of those things with a fever for 5 days to be considered Kawasaki's. Now, we've got some pictures there showing the desquamation of the hand, showing the cracked lips, showing the conjunctivitis there. All right? Myocarditis is the big risk factor, and coronary artery aneurysms, and we're trying to prevent those with treatment. And the treatment is IgG, right? IgG is the treatment for this. People have tried aspirin. The AHA has a recommendation saying, yeah, you can try it, It's reasonable, but it's a level C recommendation. And Cochrane has done a review, and they're sort of the organization that does these high-quality systematic reviews, and they're like, yeah, we don't have really good convincing evidence that ASA helps or aspirin helps. And so, again, IgG would be the answer, and I let the admitting team decide whether or not they're going to give ASA or not for these children. Kawasaki's. Okay, cystic fibrosis. So this is the most common lethal genetic disorder in Caucasians. So you think, if it's common or deadly, we should know this, right? So this is the most common and deadly genetic disorder in Caucasians. It's autosomal recessive, and it hits all the ductless glands. And so we know these children. We know about the sweat tests and the chest stuff they get, but there's other infections that they can get. They can present with intussusception. They get all this mucus plugging, and they get an intussusception. And so they could have a radar sign, a cinnamon bun sign on ultrasound, on bedside ultrasound, if they come in with bloody diarrhea, let's say. And so here are the problems that cystic fibrosis can hit. The sinuses get involved, the lungs get involved, the GI tract, gallbladder, lots of different ductless glands in the body that can be affected by cystic fibrosis. So the respiratory emergencies, you can see how they get cor pulmonale, hemoptysis, if they're getting cough, 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 pop a blood vessel, drop a lung, and go into respiratory failure. So I think we understand cystic fibrosis and the respiratory stuff, but we may forget some of the GI and other problems like the electrolyte abnormalities that can come with this, the intussusception that can come with this. My daughter growing up had a couple of friends, sisters, and they both had CF. Right? And so when they would come over for birthday parties and stuff, they had to eat, they had to take certain enzymes and stuff like that to help with their digestive system, and they were chronically, it seemed, on various antibiotics for that condition. All right, HSP, another one they usually like to ask, okay? So this is palpable purpura. So if they've got palpable purpura, you know that it's a vasculitis. If it's non-palpable, what is it? It's the platelets. They're not working well, or you don't have enough of them. So that's the dichotomous decision there. Is it palpable or not? If it's a palpable purpura, you're thinking HSP vasculitis in young children. Not in infants, but in young children. And they get it, the extensor surfaces are more likely to be involved. They can get renal involvement. You can see how the vasculitis could cause renal failure and things like that. And there are the tests there for that with regards to platelets, PT, and PTT. And there are some nice pictures to show you. I don't know how well they show up on the screen there, but showing the extensor surfaces, showing those purpura that when you feel them, they'll be palpable. Okay, from HSP to hemolytic uremic syndrome. This is acute renal failure associated with microangiopathic, small little, hemolytic, so they're going to be anemic, and low platelets, thrombocytopenia. And the cause is usually a Shiga toxin-producing E. coli 0157H7. All right? There are other bacteria and stuff that can do this. They get bloody diarrhea, bloody stools with HUS. Schistocytes will be seen on the smear. They usually have a normal PT, an INR, and fibrinogen, unlike DIC, which is the consumptive coagulopathy, which I talked about yesterday. And with DIC, usually the INR goes up, so that's the PT, and the fibrinogen level drops, and the platelets drop. It's a consumptive coagulopathy, and they both clot and bleed. All right, so it's similar to TTP, but it's the kidney involvement is the main problem. And so how I remember this, and there is just a pictures of where you can get it, improperly stored meats and stuff like that, certain sprouts and vegetables and stuff. You'll see these warnings from time to time on the news and saying, this has been recalled and stuff like that, or this restaurant chain has had an outbreak, and I didn't want to point out any one restaurant chain. A lot of the information that we have about this condition came from a town about a half an hour from where I live. About 10 years ago, they had a big outbreak of HUS. And it was like, well, how did that happen? How did they get E. coli into the whole community? And there's like thousands of people in this community. How did thousands of people get this? It wasn't a picnic. Like they didn't all go to picnic and have, the tainted potato salad or whatever it was. How do you think they got it? Water supply. Yeah, and so this is a farming community, and they're spraying with manure, and they have groundwater and well water and a municipal water system. So they had this big rain, and they have water chlorination plants that are supposed to be inspected on a regular basis. And this small town had these two brothers that were responsible for going around and maintaining the chlorinators on the municipal water supply, and apparently they weren't doing their job. And they were not necessarily always going and checking and filling out the logs, like it actually, attending to these things. And after a big rainstorm, you got all these things converging with a big rainstorm, recent fertilization, chlorinators not checked, and the whole community, everybody who drank water in that community got exposed to this infection. And there was a huge outbreak. And so there's a huge research center that was set up for this. And I remember this because of for the children, they're following them along because of the renal function and the downstream hypertension and stuff like that. Some of the other key messages that they found with that was the people that were given antibiotics did worse. Right? And so if they treated this E. coli with antibiotics, they did worse. Now, it may be observational data. Well, it is observational data. But maybe the people that got antibiotics were worse, and that's why they got antibiotics, because the clinician was like, oh my goodness, they're really bad, I better give them antibiotics, as opposed to it's the antibiotics caused further badness. But we don't routinely now give antibiotics for this condition. All right, speaking of fluids and tainted municipal water supplies, if you have a child and you're looking at how dehydrated they are, we go mild, moderate, severe, and we go under 5%, 5 to 10%, or greater than 10% like that, and then we give 50 mils per kilogram, 100 mils per kilogram, and 150 mils per kilogram is what we calculate their deficit, to be, and so that's how we stratify them. A key point in this, and this may come up in the exam, is the AAP and the World Health Organization say oral rehydration is the way to go. We shouldn't be starting lines on all these children. Oral rehydration is the way to go. And there was a study a couple of years ago comparing fancy electrolyte solutions to half-strength apple juice in a non-inferiority study design, and they found actually that half-strength apple juice plus fluids of choice were actually treated. And these are mild to moderate dehydration children. These are not severe dehydration. You offer a child what they want to drink or something that they may not want to drink that tastes a bit. Has anybody drank those electrolyte solutions? Right? You give them what they want to drink, they're more likely to drink it. So if they're drinking the solution and they're dehydrated, they do better. And also this whole idea of brat diet has gone away. So if you grew up in the era of brat diet, that is no longer the recommendation. So if they throw on a question that says, after an episode of gastroenteritis, what should the child's dietary? They should go back to eating their usual, regular, healthy diet, right? Not specifically a brat diet. Severe dehydration, that's the 20 mils per kilogram over 20-minute bolus. Just remember that if you're doing that, if you're giving normal saline, and if they've had gastroenteritis, and that's why I told you the story of my pediatric father and the gastroenteritis and the seizure that morning. Quite often during my career, I phoned up my father-in-law for pediatric advice, and I always remember that. So if you're rehydrating a child who's had gastroenteritis, they could be hypoglycemic, and then you give them 20 mils per kilogram of normal saline, they're going to be more hypoglycemic. And so you've got to give them some sugar containing, so consider D5 saline. Oh, did I have something else on there? I can't remember. No, and that's the appropriate diet. So you give them an appropriate diet at the bottom. Okay, so how do you calculate how much fluids to give for maintenance fluid? So 100 mils per kilogram for the first 10 kilograms, 50 for the next 10, and 20 mils per kilogram for every kilogram over 20 kilograms. And so this is where there's math. I have to tell you, I don't do this in my head. I have an app for it. On the exam, you won't have an app, you won't have your smartwatch, you can't call a friend, and it's not, well, hopefully you can get it down to 50-50. But the thing is that these are the calculations, some of the basic calculations they can expect you to know. We generally avoid using sedative antiemetics. I mean, everybody pretty much has moved to ondansetron now, it seemed. If you look at the graph of over time and use of ondansetron, when it came out and got pediatrics, it just went up like this, right? And having those ones that can dissolve under the tongue, the little 4 milligram tablets, and I break one in half and give them 2 milligrams there and a second 2 milligrams to go home, it's changed my practice in pediatrics with these vomiting children. We try to avoid the sedative ones. There are whole courses on ACLS for children. It's called PALS. We're not going to obviously cover that in a lecture like this. But when it comes to pediatric ACLS, some basic concepts is it's 2 joules per kilogram for defibrillation. Cardioversion, as you know, is a lower energy strength, and so it's 0.5 joules per kilogram. When you're intubating, cuffed or uncuffed, I'm almost always using cuff tubes because early in my career, I remember from my bad cases where I had a child that had an uncuffed tube that I had intubated. I had to transport them from a critical access hospital to the higher level of care, and they seized in the back of the ambulance. It wasn't a cuffed tube, and they turned their head, and I lost the tube, and then I had to re-intubate them in the back of an ambulance. Just as an FYI, that can be stress-invoking. And so you learn from that. And so now, I mean, that child's getting a cuff tube and we're duct taping that head to the board, right? And so you don't have that happen again. ET tube size, I've got an app for it. There's formulas for it. I just use the app. There's the Broslow tape that you can use as well that gives you all that information for drug dosing and for tube sizes and things like that. Surgical crikes, it depends on which organization you follow, but they say not recommended in children under the age of 12, and the narrowest part of the airway is the cricoid cartilage. And then they've got the fluid bolus there, that's the recommendation, and it's 20 mils per kilogram, normal saline. Asystole is the most common arrest rhythm. Remember, children usually arrest from respiratory problems, so we don't see a lot of cardiac arrests. If they're bradying down, that is a bad sign. Epinephrine is the drug of choice in asystole, so it's an easy algorithm to remember. It's epi for asystole. Bradycardia, like I said, usually it's respiratory compromise, those hearts will go forever. And I've seen and resuscitated children that have been down for extended periods of time and got them back. The heart still beats, and that's why the child doesn't end up doing well, either neurologically or otherwise, but their hearts are strong, young, and healthy, and so they go for a very long time. So if you're getting a brady or an asystole, that is a huge danger sign there. And we do the ABCs, right? Whereas in adults, we do the CAB, right? We do circulation, airway, breathing. But in pediatrics, we're still at the ABCs because the airway is so important. Correct causes, hypovolemia, VFib and VTAC are rare. Think hyperkalemia if you get that, or hypothermia. You need to memorize this. No, I'm just kidding. I love throwing that. If you were here for Billy Mallon, that's a destabilizing slide. I'm just messing with you now. Oh, an acid-base blood graft diagram. It's almost up there with the coagulation cascade, which you do need to know. All right, and then APGAR score. I just throw this in because Virginia APGAR is a superhero of science, and I didn't know that her name was APGAR. I thought APGAR stood for, okay, so it's activity, pulse, grimace. That's what I thought APGAR was. No, it was Virginia APGAR, Dr. APGAR's last name, and she's a superhero of science. All right, neonatal resuscitation priorities. Dry, warm positioning, right? Suction and you're rubbing them, right? You ever seen, a newborn and, they're rubbing them with towels and they're stimulating them and they've got them under the heat grow lamps and stuff like that. Supplemental oxygen, bag, valve, mask, ventilation, chest compressions, intubation, epi's your drug of choice. All right, for neonatal resuscitation priorities. Again, this is a superficial coverage of these types of issues. And then we have a whole bunch of pediatric pearls. And so when I inherited this lecture, Rick said, if you've got enough time, go through the pediatric pearls that are there. If you don't have enough time because of lack of time within the course, they can review this in the airport on the way home. We do have a little time, so I'm going to pull out some of the highlights. But it's a list of 32 different pearls from the pediatric section. First of all, it's neonates and respiratory. You got to respect their system. How do they increase oxygenation and stuff? They don't increase by volume. They don't sit there and just expand their chest. It's usually respiratory rate. So they start going fast. And if you get a breathing rate of greater than 60, you should be worried. All right? That's an abnormal vital if they're huffing and puffing, if they're tachypnic. Newborn infants, right? They can have apneic spells. They can go 20 seconds, and it's very concerning, right? But it's still actually normal. But it's obviously very concerning for the parent to watch their child, especially if they're a preemie, have 20 seconds, right, of this with braddying down and getting cyanotic and getting poor tone. Sounds like a brewy in an otherwise well child. Bradycardia is almost always due to hypoxia there. Respiratory rate, again, greater than 60, and if they're grunting, nasal flaring and stuff like that, it's about the respiratory. That intercostal indrawing, that tracheal tug, that type of thing gets you worried. Fever of greater than 39 degrees in the presence of a UTI equals pyelo. Okay? 5 to 10% of them will have bacteremia. The incidence of bacteremia and sepsis in a febrile children 3 months of age or less, so this is early on, they may only have one immunization, is 2 to 3%. If they're ill-appearing or significant abnormality laboratories, they can be even higher rates. Now, if you have immunized children between 3 months, so they've had their first shot at age 2 months, and 36 months, almost the completion of their primary series, and a well-appearing but febrile child, their risk of bacteremia is less than 1%. Okay, it's unlikely. If you've got an older child, so greater than 3 months, they're out of that neonatal period, right? You know how we brought that number down. When I started, it was everybody under 3. That was the easy case. You know, child could come in 2 months and 29 days and had a fever, call peds. Now it's on to the next case, right? You know, then it dropped down to 2 months. Now they're trying to push it down to like 1 month. Right? 1 month and a fever in a child, that's all in. But you know, you can start doing some other stuff where you're not necessarily doing all the stuff in that 2 to 3 month range. The safest approach to febrile children less than 30 days is that's the full on. That's still that under 1 month, that neonatal period, you're all in for those. The AAP has some recommendations about testing for UTIs in all febrile girls and uncircumcised boys less than 2 years of age if there's no apparent focus. So if you have a child that has a fever, you're thinking UTIs in girls and uncircumcised boys under the age of 2, and then 1 year of age in circumcised boys. Analgesics, this is for oral or topical. If no tympanic membrane perforation is an important part of treating otitis media, what we do is help alleviate pain and suffering. And so, of course, the antibiotics, the number needed to treat is somewhere around 17. You need to treat 17 children with acute otitis media so that they have less pain on day 2. Right? So it's going to take until day 2 for 1 out of 17 children to feel better clinically. So give them something for an antipyretic or an analgesic. And just with the antipyretic thing, the AAP says if you have a well child who has a fever, we should really emphasize treating the child, not the thermometer. If they're well, they're fine. If they're suffering and they're miserable because of the fever, of course give them an antipyretic. And another thing is that antipyretics don't prevent a repeat febrile seizure. There was a recent Japanese study that suggested that if you gave rectal antipyretics to children that had already received rectal benzodiazepines for their febrile seizures, you could prevent a recurrent febrile seizure in that febrile illness. But there was a lot of problems with that study, so I still stand by you don't need to, make a parent feel guilty that clearly they had a repeat febrile seizure in their next illness because you weren't on top of their fever enough, right? It doesn't reduce the incidence of recurrent febrile seizure for the next febrile illness. Some other pearls there is one is that x-rays can confirm a foreign body, so it can rule in if you see the foreign body, but if you suspect a foreign body and you get imaging and you don't see a foreign body, it can't necessarily rule it out because a lot of foreign bodies will not be radio opaque. Let's see, in a constipated child, a rectal exam reveals tonic constriction of the anus with an empty rectum. Hirschsprung's disease, yep, that's another pearl. What was that? Check the throat. Oh, abdominal pain. Yeah, I when I read this, it was funny because in my, you make all your, well, not all your mistakes, but a lot of mistakes in your first year of practice. And I remember calling the pediatric surgeon and assess this child that I thought was a slam dunk appendicitis, tonsillitis. And so children with belly pain, it may not be focal belly pain, it may be their belly hurts while they're sick. And so give them a good head-to-toe checkup, and that's a just good reminder, and I've always remembered that case. Although very uncommon, UTIs can have coexisting viral infections, sure. Nitrate testing has less sensitivity, that's true positives for a UTI when caused by a gram-positive bacteria. So we all go, woohoo, yay, nitrates, spike the ball, right? It's a UTI. But if they don't have nitrates, it doesn't mean they don't have an infection. If it's a gram-positive infection, it's the gram-negatives that are producing the nitrates necessarily. Migraine headaches in children, rather than sudden onset, intensify over 10 minutes and maximum at 1 hour. Okay, so migraine headaches in children. About a third of migraines in children are unilateral. Okay. Ergotamine should not be used in these migraines. A serious cause of headaches will have concomitant neurologic, most serious. Yeah, so if you've got a really bad headache on, blunt head trauma in children can be accompanied with diffuse cerebral swelling and increased CSF pressure and altered mental status, sure. And children have concussions should not be allowed to participate in contact sports until cleared by another physician. This pendulum is switching, right? We're seeing more and more studies. It used to be, when I was growing up and playing hockey and stuff like that, you hit your head and you had a clear concussion. It was like I sat out a shift, right? And then it was right back in. Put me in, coach. I want to play. And then the pendulum became, oh, he had a microaggression. It hurt my head. I'm out for a semester. And I'm obviously being facetious about that. But, now we have people that just ding their head slightly, and it's, oh my goodness, right? Now I think the pendulum is swinging back more towards the middle, where it's not like you have to have complete bed rest for like extended period of times. Now the concussion literature seems to be going, listen, you've rung your bell, you've had a concussion, take a couple of days of complete rest, and then slowly increase activities as tolerated, and if your symptoms come back, then you pull back from the level of activity you're on. Because like what in medicine has 2 weeks of strict bed rest does anything, right? If anybody's here out long enough, they know, oh, we used to put people in bed for 2 weeks if they threw their back out. Watch them get up after 2 weeks of lying in bed. Is their back better? No, and so 2 weeks of strict bed rest. We're seeing more and more with regards to the concussion literature where it's swinging back to a couple of days and then slow progression and return to sports. Children presenting with metabolic crisis, inborn errors of metabolism, resultless of cough, usually dehydrated. It's usually acidosis and hypoglycemia, and that's one of the points I made earlier. Don't give insulin and glucose to treat hyperkalemia in children. They can have a vigorous response and just crash their sugar. Unless clearly vasovagal, boo, to a child, get an ECG. You're looking for things like Brugada and stuff like that. Syncope associated with exercise, so sports-related syncope. You should be thinking about structural problems of the heart as well as electrical. Other risk factors for serious causes of syncope, watch for those family histories and things like that. And loss of consciousness occurs simultaneously with shaking movements, with seizures, but less after loss of consciousness. So that's the thing when you have somebody syncopized versus a seizure and trying to tease out the difference between the two. That's it. I'll leave it there, finishing on time at 8:45 for Peter. Thank you very much. I'm going to be heading back to Canada. I will say if you have any questions or concerns about any of the lectures I gave or any other questions, you can email me. I'd be happy to respond to you. My personal email is thesgem or thesgem@gmail.com. So that's my email. If you have any questions, I love talking nerdy, so send me your questions. Good morning. I see you too.
Okay. Good morning, everybody. You are almost there. I think the only thing between You in the end of the course is me now. So we're going to do dermatology. The good news about this is there's a lot of pictures, so there's not quite the same intensity of information of what you've been dealing with for the last several days. I think when you're approaching dermatology, obviously there are some classic photos where if I were to show you one of these photos or they were to show up on the board exam, you could look at it and say, I know exactly what that is, and we're going to just remind ourselves of the important facts about those things so you can get all these questions right on the exam, okay? So let's go through it. We'll go through, some things that you're pretty familiar with to start. Atopic dermatitis or eczema. This is sometimes known as the itch that rashes rather than the rash that itches because you start itching and the more you get, the more it starts coming out, all right? So eczema, start itching, starts coming out like crazy. You know what this looks like? It's redness, it's some crust, some fissures. If you scratch it a lot, you'll have excoriations over it. It's a chronic skin condition, very, very itchy, recurs over and over for folks. With adults, we tend to think about it in classically the antecubital and popliteal fossa as a great place where you could see it. Of course, it can be in lots of places, but antecubital popliteal fossa. In infants, in infantile eczema, oftentimes you have this stuff on the face and the scalp, okay? So it's kind of all around their face. I think about it, it's like where the little infants can reach and they're itching up on their face and they're getting this scaly stuff on their face. And you know that it's worse when you have dry skin conditions. It's worse in the winter. It's worse if you've been, using hot baths and soaps and detergents and things like that. So that's eczema. Oh, another thing, by the way, just to remind you, is that it comes as a triad, right? Or it can come as a triad. That is eczema, asthma, and hay fever, right? So allergic rhinitis. So eczema, asthma, and hay fever come together. So if you're seeing somebody with a rash that you think might be eczema, ask them, do you have a history of asthma? Do you have a history of hay fever? And if they have those, that just kind of helps you think a little more that they're living in that kind of atopic world and that may be what's going on. Treating eczema is pretty simple, topical corticosteroids, maybe something for itch. Complications, of course, you can get bacterial superinfection, of course, but you can also get this weird thing we don't see that often called eczema herpeticum. Eczema herpeticum is when you actually get a herpes simplex virus infection right on top of eczema. So it's like you got eczema and you took herpes simplex and stuck it right on top, all right? And I'll show you some pictures that might be consistent with that. We'll see. Okay, this is pretty good classic picture, right? We got dry, scaly skin. There's some excoriations on top of it. It's in an antecubital fossa. That looks pretty good for being eczema or atopic dermatitis. This is infantile eczema, the same sort of redness and kind of scaliness and itchiness going on there. There's not honey-colored crust here. This is not impetigo. It's just that red, kind of itchy stuff. It can also be around the ears as a classic place to see it in young kids. But that's infantile eczema. Another adult, this is a scaly eruption you see. It's dry, scaly skin all over the place. Could be a lot of things, but when I look at their antecubital fossa, right, I see a bunch of it involved in the antecubital fossa there. And so that just gives me a hint that I think, this might be actually eczema, not just a lot of other scaly things it can be. This is, again, more eczema. Now we have a popliteal fossa. You see some redness, a little bit of scale. And here you're actually seeing some hypopigmentation. When there's lots of itching, whenever there's lots of itching going on, you can get hypopigmentation. So it's, again, popliteal fossa. That's your hint for this one. All right, so that's pretty straightforward stuff. Let's talk about contact dermatitis, allergic contact dermatitis. There's a couple of different types of contact dermatitis. You can have something where you touch something and you immediately get a reaction, okay? That's probably like more some chemical thing going on or whatever, right? That's not your allergic contact dermatitis. Allergic contact dermatitis are these delayed hypersensitivity reactions. These are like your poison ivy, poison oak, poison sumac, those sorts of things. Nickel-plated jewelry would be another classic one for a contact dermatitis. Hair dyes, detergents, these things that cause an allergic reaction, delayed type. Again, you get redness, itching, vesicles, little blisters kind of going on there, and they're going to treat them with steroids if it's severe. If it's mild, you're not, but otherwise, some steroids. So again, here's a contact dermatitis. You see some redness, you see a bunch of little vesicles. The thing here that makes me think this is a contact dermatitis rather than any other sort of dermatitis is that, see how the vesicles are lined up in a linear fashion over here? See right there? It's like a line of vesicles. Remember, contacts are places where you get contact, so it tends to be in exposed areas. And whenever I see a line, it makes me think someone like brushed up against something, okay? So that makes me think it's a contact dermatitis here. This honestly looks more like cupping than a contact to me, but let's just go with it and assume that there was something there touching it that there was a reaction to. Here you can see in the same place where the watch is sitting, there's that same sort of, scaling and thickening of the skin going on there. It's itchy over there. It's another contact dermatitis, probably nickel-plated back of that watch. Pretty classic. And again, the only hint that really makes me think contact dermatitis, sure, there's redness, there's some vesicles, but I see that linear stuff there. Whenever I see linear over on the slide, I really start to think about a contact dermatitis, and that's your hint. Okay, and there's the poison ivy. Good stuff, right? Get it all over you. There's actually, you can have inhalational injury. I don't know if anyone's seen this, where people are raking up their leaves and they rake up poison ivy and they burn it all, and they can actually get an inhalational injury from it as well. That's pretty nasty. Where I live, we have a little hill on the back of our house, and it's poison oak, and it's all the time. I mean, this stuff, I can't grow any plant. Like any plant I ever try to grow always dies, except for poison oak. All right, this stuff, and I don't try to grow it, you can't kill the stuff. It just keeps coming back over and over and over. So lots of reactions we see with that. Okay, exfoliative dermatitis, also known as exfoliative erythroderma, which I like because it's red skin, right? So it's exfoliative means you're going to have some scaling and peeling, and erythroderma meaning red skin. So this is a generalized dermatitis all over the body. Red, warm, scaly in an adult patient. So you got an adult, they're red, they're warm, they're scaling all over the place, and eventually they exfoliate, okay? Usually there's some sort of underlying illness going on, all right? Some sort of underlying illness that's going on that you want to try to figure out what it is. And for the boards and for practice, kind of some of the big common ones would be some drugs, meaning, medications, things like that, and lymphoma and leukemia. So lymphoma and leukemia would be ones that I would do. So if they show you an adult who they say had this red rash and that's kind of scaled all over and it peeled all over, and one of the things you want to be thinking about are lymphoma, leukemia, different medications that they may be taking as well. Typically, men over 40, not surprisingly, the sort of complications you get when you're red and warm and scaling and peeling all over are, heat loss, fluid loss, electrolyte loss, superinfection, just those usual sort of things you get when your skin's kind of disrupted, all right? These patients can be sick, they get admitted, and they oftentimes will get steroids as well. This is what it looks like, or at least part of it. Here's the hand, you see some red hand, you see some peeling hand. There are other things that can do this, but again, this is going to be like all over the body in an adult. Psoriasis, I think, is a good one for the exam because, the appearance of psoriasis can be very, very distinctive, right? And because of that, if I give you a picture of somebody with psoriasis in the right spot, you should be able to make that diagnosis pretty much just from looking at that photo. So what is psoriasis? As you know, it's a chronic papulosquamous eruption. So basically the skin cells just keep building up and building up and building up. And they build up and they form these plaques. And these plaques have scale on top of the plaques, all right? And if you look at the scale, it's almost like a silvery white appearance to the scale. And the plaques are very well demarcated plaques. And I'll show you pictures in a minute. Classically on extensor surfaces, but they can be in all sorts of places, the waist, the hairline, genitals. I mean, you can have psoriasis all over the place, but extensor surfaces would be kind of a classic one. If I were going to create an exam question, I might give you an extensor surface, if I want to lead you towards psoriasis. Remember that you can get pitting of the nails. The nails can get involved and look kind of very indented with pitting of the nails. That is associated with psoriatic arthritis. So when they have the nail pitting going on, that's also associated with psoriatic arthritis. Lots of different treatments for psoriasis, steroids, tar, UV light, methotrexate, lots of different things that can be used for psoriasis. This was a great visual diagnosis, right? There's probably not else that's going to look just like that. It's a scaly plaque on an extensor surface, very well demarcated there, and it's got that very classic white, silvery almost appearance to it, right? I mean, yeah, could that be a fungal infection? I guess it's scaly, that sort of thing, but geez, extensor surface, that thick white look to it, they're probably going to lead you to psoriasis. Here's some nail involvement. You can see the nails that are involved on this patient with psoriasis. These are fingers, okay? I mean, again, I don't think about psoriasis on the fingers normally, but I guess it certainly can happen, and here it is. This just miniature versions of what I was showing you. Little small, scaly, silvery white things. When you see that, think psoriasis. Okay, let's move on to dandruff. Seborrheic dermatitis. This is just dandruff, right? This is where you get the scaly scalp, the little white flakes. They drop off, they get all over your dark suit, that sort of thing, right? Okay, so it's that sort of thing. That's what dandruff is. This is associated with a fungus called mollusacea. So mollusacea is the fungus that is associated with dandruff. It's not contagious. It's not like you're going to catch this from somebody, but it is a fungus that builds up, and it does seem to be associated with this as well. And as you know, it can get lots of recurrence of this, particularly in the winter, when there's cold weather and things like that. The seborrheic dermatitis, the dandruff tends to be on the scalp, but remember, seborrheic dermatitis can involve the face. And when it involves the face, it tends to be in what's called a T distribution. So across the eyebrows and on the sides of the nose in a T, like this and like that. So it's a T distribution, eyebrows and the sides of the nose that you can see as well. And you can have seborrheic dermatitis get on the body as well, okay? And when you're seeing that rash on the body, look for the T on the face, look for the scalp to help you kind of figure out, I think this is actually seborrheic dermatitis, just more severe going down onto the body here. Treatment for seborrheic dermatitis is basically anti-dandruff shampoos. You can use the over-the-counter stuff, or you can use ketoconazole shampoo, because remember, it's associated with this little fungus. So over-the-counter stuff or ketoconazole shampoo is going to work. Also want to mention that seborrheic dermatitis can be seen in patients with HIV. Obviously, most patients with dandruff are not HIV positive, but patients who have HIV/AIDS can have pretty significant seborrheic dermatitis. So if you see somebody who looks kind of, cachectic and things like that going on, and they've got the seb derm all over their face and body, they probably need an HIV test, all right? Okay, so here's some pictures of seborrheic dermatitis. This is your classic one. It's the scalp. There's a bunch of little, white flakes there, right? Look at all this stuff there, all these little white flakes. They look like they just want to drop off and, get on you, right? So that's classic look of seborrheic dermatitis. I think you wouldn't miss that. This is another appearance of seborrheic dermatitis. This is more of a yellow, waxy appearance to it. Almost looks like melted wax on there, right? But it's on the scalp, it's itchy, it's the same thing. So don't be fooled. That is seborrheic dermatitis, and you will sometimes see it that way too. Okay. Next to talk about is pityriasis rosea, okay? If you remember this rash, this is the one that we tend to see in kids or young adults. Nobody knows what causes it. We don't know what causes it. It's not contagious. It doesn't occur in epidemics or anything like that. It just happens sometimes. We don't know why. And if you remember the way things kind of work with pityriasis, the first thing you get is what's called the Herald patch. And the Herald patch is a little patch. It's like maybe 2 to 5 centimeters, circular or oval patch, somewhere on the trunk. So maybe on the front, maybe on the back, this little patch. And it's, it's generally their skin color, in white folks, it tends to be, kind of like a pink salmon sort of color is what it looks like. And there's a little bit of scale on it, all right? There's a little bit of scale on it. When you look closely at the scale of pityriasis, by the way, just in general, the scale tends to go around the outside of the lesions. It's not like scaling all over. It's called collarette scale, so it goes around the outside of it. But you start with this Herald patch, this 2 to 5 centimeter patch somewhere on the trunk. Maybe they saw it, maybe they never even noticed it. It's called a Herald patch because it heralds the arrival of the rest of the rash, right? So a couple of weeks, 1 to 2 weeks after this Herald patch, you get the rest of the rash. And the rest of the rash are just like mini Herald patches, okay? They're more like, 1 centimeter, 2 centimeters at the biggest, right? Little small mini Herald patches, a whole bunch of them all over the trunk. And of course, the classic distribution is what? The Christmas tree pattern you're supposed to see, right? So you're supposed to see these lesions almost like they were the little bulb ornaments on a Christmas tree limbs going like this, right, on the trunk, kind of coming down like that. That's what you're supposed to be seeing is this Christmas tree pattern. So you start with the Herald patch, a little bit later, week or two later, you get this rash kind of all over. Think about secondary syphilis, okay? Secondary syphilis can look like a lot of things that can look like this. Pityriasis will never involve your palms and soles. Okay, if you think someone's got pityriasis and it's their hands and feet that are also involved, it's not, okay? It might be secondary syphilis. Don't, just kind of wave hi, don't shake hands, all right? That sort of thing, all right? Treatment for this, there's not much to do. Oftentimes it's itchy, so you can get some antihistamines, but it doesn't have to be itchy. It's basically symptomatic stuff and it goes away. So let's look at it. Okay, so here you can see, again, this is not the Herald patch, this is when the whole rash has come out here, but you get the sense of kind of the size, the shape, the look, the distribution of all these various lesions, and very clearly you can see the Christmas tree, right? Yeah, I mean, it's right down here on the slide. That's the Christmas tree, okay? So this is kind of hard. This Christmas tree pattern, I think sometimes you got to have had a lot of eggnog, you got to be hallucinating to see the Christmas tree pattern, okay? But they're supposedly kind of lining up like the limbs on the Christmas tree. Here again, you see the size, the shape, kind of what they look like, these sort of kind of like little scaly things. That bigger one might have been the Herald patch. There you go, another bigger one and some smaller ones. And you see the scale on it, how it just kind of goes around the circumference almost? See that scale? It's kind of almost around the circumference. It's not like totally scaly all over. That's a sign for pityriasis. Okay, so that's pityriasis, pretty simple. Herald patch, and you get the same thing in the Christmas tree, not much to do about it. Petechiae and purpura, this is just kind of a general concept slide, not much to memorize here. Remember that, petechiae and purpura are kind of like bruising, right? It's when you've got blood outside of your blood vessel. So when we see a red rash, we're always asking, does it blanch or not blanch? It blanches, that means it's just vasodilation, right? It's just vasodilation, the blood is in the blood vessels, you push on it, it blanches, you let go of it, it comes back. That just means the blood's inside the blood vessel. When it's not blanching, the blood's outside of the blood vessel. You now got petechiae or purpura or something like that. Petechiae are less than 3 millimeters, purpura are at least 3 millimeters, okay? So that's just by definition, I guess, the way the dermatologists call it. So little ones are petechiae, bigger ones are purpura. When you see this rash and you say, okay, it's not blanching, this is like 4 millimeters, so I think it's a purpura. When you see purpura, the next thing you always want to do is feel the purpura and say, is it palpable purpura or not palpable purpura, okay? Close your eyes, run it across the rash. Is it palpable purpura or non-palpable purpura? Palpable purpura equals vasculitis, okay? Whenever you have palpable purpura, there's a vasculitis. It doesn't tell you the cause of the vasculitis. It could be autoimmune, it could be infectious, it could be all sorts of things. But palpable purpura is vasculitis, so that's one of the things I want you to just remember about this. And of course, the treatment just depends on what's causing it. Nothing to memorize here. So here's some pictures. You see some smaller petechiae on the fingers, maybe some purpura there on the back of the hand where it's starting to get a little bit bigger, right? You know that these look like petechiae and purpura. Again, a whole bunch of purpura on this patient. You don't know exactly what's causing it. This might be HSP. It's hard to tell, right? If they were febrile, maybe I'd think meningococcemia or something. But those are purpura. And of course, treating depends on what the cause is. Hives is something you see very commonly in the emergency department, so we'll just go through it real quickly. You know what this looks like, right? This is some sort of an allergic reaction, essentially, to something. Oftentimes we don't know what it is that they're reacting to. It's very itchy. They get these wheals, right? These kind of elevated areas of edema in the skin, these wheals, and these lesions tend to move around. So even if you've had a rash, like an urticarial rash for 2 days, each individual lesion tends not to be in the same spot for 2 days. It tends to kind of move around a little bit. So that's a good question to ask the patient. You say, I know you've had this rash for 2 days, but like that spot right there, has that been there the whole 2 days, or is it kind of like moving around and coming in different places like that? And they'll usually tell you it's moving around. It's medicine, it's not perfect, but that's a good history to make you think about hives. So factoids to know, this is IgE mediated, okay? So it's it's like allergic, right? It's an IgE mediated, the mast cells degranulate and release histamine. So it's IgE mediated, it's edema in the superficial dermis. So it's superficial edema, and it's IgE mediated. That's urticaria, all right? And treating it, it's usually self-limited. Usually there's nothing to do for it other than give some antihistamines, maybe some steroids. If it's real severe, you could use some epi or something like that. But usually antihistamines, H2 blockers, right? Steroids, that sort of thing if you need it. Something for itch. This is really nice. Nice picture of some urticaria, some wheals there, right? You see the kind of the look, the red kind of elevations, some edema in the middle. That's some urticaria. This is a great picture of urticaria. Actually, the urticaria came from the Saxon word for heaven. I should say, actually, hives came from heaven, because hives, like from heaven, from the Saxon word, to raise up. So it's like to raise up. So hives is like raised up. And you can see why they would call that like heaven. These look like little clouds, right? So there's the normal skin is in the middle there. And this is a big old wheel here, big, wheel from hives. It looks raised up like a cloud. So hives from heaven is basically where it comes from. So that's urticaria. Again, IgE, superficial edema. Angioedema, in contrast, is bradykinin mediated, not IgE mediated, and it's deeper edema, okay? So it's deeper edema. So whereas hives is IgE and it's real superficial, angioedema is bradykinin mediated and it's deeper edema in the dermis, okay? Deeper edema. And you know what, you've seen patients with angioedema. You remember that there's at least 2 special types that we need to think about with angioedema. One is ACE inhibitor angioedema, right? They'll give you a patient who has a history of hypertension and they're on some medication. It was an ACE inhibitor, right? So ACE inhibitor angioedema, edema. It can occur within hours, it can occur within months, it can occur within years, okay? So anybody who comes in with angioedema, you just got to see if they're on an ACE inhibitor and obviously have to stop it if that's what's going on. The other type of angioedema that's special we need to remember is familial angioedema. Familial angioedema is obviously an hereditary angioedema. So these patients have a deficiency of C1 esterase inhibitor. And by having a deficiency of this, bradykinins build up, right? And I told you this is all bradykinin mediated. So they have the C1 esterase inhibitor deficiency, they get this elevated bradykinin. And these patients present with recurrent episodes of edema over and over and over. The face, the extremities, the bowel wall, the larynx, they can get airway stuff involvement as well, okay? So they get recurrent edema, recurrent swelling. The recurrent belly edema, you know, in the abdomen edema can cause recurrent abdominal pain. They come in with that non-specific belly pain you can't figure out, right? That sort of thing going on. They can get recurrent bouts of edema that happen over and over. You know, when they're having these episodes, you're giving them something for pain, you're giving them some fluids if they need it for their belly. But basically what they really need here is you need to give them back the C1 esterase inhibitor concentrate. And if you don't have that handy, you can give them some FFP, all right? So FFP, or the C1 esterase inhibitor concentrate, is what you're trying to give them back because that's what they're missing, and that's a special thing. The other thing, we don't talk about a lot of genetics on the EM boards, but I will just mention this, that it is autosomal dominant. And why do I tell you that? That means one of their parents, their mom or dad, had this and should be expressing it as well. So when you see a patient in the ED who's having recurrent edema and you're not quite sure what's going on, ask them a family history, because this actually may help you. Say, did your mom or your dad ever have this sort of thing where they get swollen face and extremities and that sort of thing? And if they say yes, another hint that this is familial hereditary angioedema. All right? So angioedema, deeperdermis, bradykinin mediated. If it's an ACE inhibitor, stop the ACE inhibitor. If it's the familial one, they need the FFP or the C1 esterase inhibitor given back to them. And this is a classic example, right, of angioedema. You've all seen this, right? Big swollen tongue going on there. And you're like, oh, that's not good, right? And you get the airway box, you bring it to the bedside, and then you do what I always do as my second thing after getting the airway box is you see, like, how close are we to sign out, right? That's really important, right? Can I sign this airway out? I'm wondering about that. Maybe I should send a urine or a troponin or something like that. I don't know, you know. Just kidding. So obviously these things can be a scare away, lots of angioedema here. The good news actually about intubating this patient is that patients with angioedema, it tends to be very anterior, and the back is actually pretty well preserved. So these are patients where if you do fiber optic intubations, you can actually do it relatively easily. You give them a little, little sedation, topical stuff, a whole bunch, and then you just kind of go in there. And the back actually isn't usually look as swollen as this, usually. But still, see how close you are to sign out. Okay. Okay, so that's angioedema. Let's talk about erysipelas as our next thing. This is pretty simple. Erysipelas is cellulitis, okay? It's cellulitis, but it's a special cellulitis because it's caused by group A strep. Okay, so it's group A strep cellulitis, all right? Tends to be in elderly patients. It can be in infants and toddlers as well, but the classic thing they might give you an exam question on would be an elderly patient who's got this, okay? It's cellulitis, so it's going to look like cellulitis. It's red, it's warm, it's tender, that usual sort of stuff. But it's very well demarcated. You know how when you've seen patients with cellulitis, like let's say on their leg, and you're sending them home and you're taking the pen to mark where the edge is, right, to say, if it gets worse, let me know. And you're trying to mark the edge, and most patients with cellulitis, it's hard to find the edge. It's kind of like, well, I think it's, maybe it's a little there, you know. In erysipelas, it's a well-demarcated cellulitis. So it's a really nicely well-demarcated cellulitis, which is one of the hints to its diagnosis. It'll oftentimes be on the face. It can also be down on the legs as well. But if I saw a well-demarcated red cellulitis on a face of an elderly patient, I'd think, they're trying to get me to think erysipelas, not just your typical cellulitis, all right? And treating it. So because it's group A strep, if we really knew that's what it was, you could actually treat it with penicillin because you wouldn't need to cover staph. Now in the real world, we all know, we never know exactly, is it strep, is it staph, that sort of thing, we're going to cover staph. But for the boards, if they gave you what was a classic picture of erysipelas in the classic patient, and penicillin is one of the answers, that actually could be the right answer because they're trying to get you to know, no, this is group A strep erysipelas, I'm going to use pen for this one, not the usual stuff. Okay. So here we have an older patient. I won't call it elderly since I have gray hair too, but it's got a little gray hair. So got an older patient. Looks like a cellulitis on the face. It's red, it's warm, it's tender, that sort of thing. But look how relatively sharp the border is, right? I mean, I could trace that border. You know, it's not that hard to trace. I could trace it. Oh, maybe a little fuzzy there, but not much. I could trace that border all the way around. So that's erysipelas, group A strep, penicillin. That's the factoid on that one. Erythema nodosum, red nodules. I love that. I love when they name things like the way it helps you. Red nodules, erythema nodosum. This is actually a paniculitis, which is an inflammation of fat. So you know what that's going to look like. If I tell you have a red nodule and it's fat, you know it's going to be a deep sort of thing that's going to really hurt, right? A red inflamed nodule of fat going on down there. So that's what this is. It's basically kind of a very localized vasculitis. It's a paniculitis of the fat itself. Classically, the pretibial region. It can be in the arms, it can be other places, but you know, if they're showing you on the board exam, it's probably going to be the pretibial region. You see these red, painful nodules in the pretibial region. Sometimes they have a kind of little purple, violaceous look to them as well. They can look like bruising in the pretibial region, that sort of thing, right? Where people do tend to bump into things. The erythema nodosum itself, you know, congratulations if you make the diagnosis, right? But the real question isn't the erythema nodosum, because it's going to go away on, you know, usually on its own over weeks to months. It's a marker for other issues, for systemic disease, okay? So you figure out it's erythema nodosum, but the test question is, well, which thing is associated with this? And so you have the list up there. Lots of different drugs, or I should say medications, can do it. So oral contraceptives, sulfa, penicillin, you know, common type medications. Infections like TB or fungal infection, coccidiomycosis would be one of them, so TB, fungal. Sarcoidosis could do it. Ulcerative colitis, right? So IBD and ulcerative colitis would be one of those that can do it. And then malignancies, lymphoma, leukemia. So they could give you the, you know, they give you the picture, you figure out it's erythema nodosum, but they ask you which of these things might be more common in this patient as an underlying cause. And you just got to know these things: sarcoid, ulcerative colitis, TB, fungal, that sort of stuff. Okay, more common in women. Again, it resolves generally on its own over many weeks. Figuring out the treatment is about dealing with the underlying cause. Okay, here's your picture. It's a pretibial region. It's a red nodule. It's painful. That's erythema nodosum. Okay, that's a gimme right there. Here's another patient, elderly patient. And this one, usually they're usually more middle-aged, but it can be all sorts of ages. You see red nodules, almost looks purple, violaceous sort of thing, looks like bruising. You're asking this patient, like, what happened to you? Like, nothing happened to me. Like, did you walk into something? Did you bump into something? No, nothing happened. Did somebody hit you? You know, are you safe? Like, what's going on here, right? This was not abuse. This was not trauma. This is just red nodules. Red, painful nodules, pretibial region. Just go straight for erythema nodosum. Okay. Drug eruptions. There's a lot of words on this slide. I'm going to make it real simple. Drug eruptions, the big take-home from this slide, the thing I want you to remember about drug eruption is any acute symmetrical rash that you see, you got to consider a drug eruption, meaning a medication, one of their meds, okay? Any acute symmetrical rash, you got to think about meds, okay? It can be IgE, it can be IgM, it can be urticarial, it can be morbilliform, it can be erythema multiforme, it can be, you know, it can be lots of things. The bottom line is any acute symmetrical rash, you got to be looking at the med history because that could be involved, really important. The next three things I'm going to talk about are erythema multiforme, Stevens-Johnson syndrome, and TEN, toxic epidermal necrolysis, okay? And we used to think about them as three separate diseases, right? They'd be in different sections of the derm talk or something like that. They're just three different things. But the more recent thinking is that this is actually the same sort of disease, the same sort of causes, but it's just a spectrum in how your body's reacting with this kind of hypersensitivity reaction, right? Where the mild version is erythema multiforme, kind of the moderate version is Stevens-Johnson syndrome, and the maximum version is TEN, toxic epidermal necrolysis. But the same things cause them, okay? And it's the same sort of thing. It's a hypersensitivity reaction, just looking different in your skin. Okay, so erythema multiforme is the mild form of it. Lots of things can cause it. You know, lots of different medications can cause it. Things like a mycoplasma infection, herpes infection, little herpes outbreak on the lip, and now you come out with this erythema multiforme. It can be on the palms, soles, extensor areas as well. And you remember the classic thing here is the target lesions, the bullseye, the target lesions. So they look like a target. They look like they've got a center that you want to, shoot an arrow into or something like that. Not much to do for erythema multiforme. If there's something causing it, get rid of it. But oftentimes it's benign. They had a little mycoplasma cough or something like that. Now they've got this rash. Not too much to do about that. Here are some pictures of erythema multiforme. You see multiple lesions. And by the way, these tend to be symmetric. I'm just showing you one limb here, right? But they shouldn't just be on one limb. There should be stuff on both sides, right? So this tends to be a diffuse rash. So you can see these kind of look like target lesions. These ones look a little bit elevated. They look like got maybe a little bit of a target in the center of them, right? That's erythema multiforme. I like this one. This is a really good picture of it as well. It's involving the palms. That's definitely targets there. We got a bullseye going on there. If you looked at the other arm, there should be something going on there too, not just that one wrist, okay? That's erythema multiforme. That's the mild form of this disease. Pretty common in young kids as well. Not too much to do about it, right? Now, Stevens-Johnson syndrome is when you have more lesions. You got more stuff going on here. Now you've got like 10 to 30% of the body surface area involved, or you have mucosal involvement, mucous membranes, things like that going on, okay? Or you have bulli. You can have bullous form of the erythema multiforme, right? So if you've got bulli or lots of skin involved now, or mucous membranes involved, now we're talking about Stevens-Johnson syndrome. Same things cause it, but now this is a sicker patient, right? This is a sicker patient. This is a great picture for Stevens-Johnson syndrome, right? This is like the classic one. We've probably seen it on exams we've taken at different parts along our career all the time, right? So you see these sorts of, just kind of erosions essentially of the mucosa going on there on the lips. That's Stevens-Johnson syndrome. This patient is sicker. They may have fever. They look sicker. Again, now you've got Stevens-Johnson's. You just got a lot more lesions than you had in erythema multiforme. You got a bunch of confluence going there on the right thigh. It's just like there's more going on. That's Stevens-Johnson's. Toxic epidermal necrolysis is when it's gotten real severe spectrum of this same disorder, right? TEN is when it's gotten really bad now. And now you've got like more than 30% of the body surface area involved. More than 30% is involved. And remember, what you get with TEN is sheets of peeling skin. So you get cleavage in the skin, and it peels off. It looks like a second-degree, sunburn or something like that, a second-degree burn in some ways, right? It's like peeling sheets of skin, okay? Same sort of things that will cause this. They also get this thing, if you remember, called Nikolsky sign. Nikolsky sign. So basically, this Nikolsky sign, there you go. Nikolsky sign is if you were to take your finger and just kind of like rub gently along any place where there's involved skin, it just rubs right off. It just peels right off. That's because the cleavage plane is just very, very high. So the top layer is really, really thin. So it's easy to peel off. Just imagine if you were to go to your bathroom in your hotel room here, put a tissue, a Kleenex on the counter, pour some water on top of it, and then push. It's going to rip, right? That's what it's like. That's a Nikolsky sign that you get with TEN, with this kind of really thin skin as well. Obviously, this is a bad disease to have. When you got peeling skin all over your body, that's not good. It's kind of like burn stuff, right? Infection, dehydration, electrolyte loss, all those sort of things. So these patients get admitted. They get admitted to the ICU. Actually, the very first patient I ever had as an intern, very first patient I had to take care of, was a really unfortunate gentleman who developed TEN from dapsone. So really, really sick patients. These patients do not do well. Okay, so here you go. We're demonstrating the Nikolsky sign. You see some involved skin there. You do a little push, and look how it just peels right off. Okay? Now, I am really hoping that that is the patient's thumb and not the examiner's thumb, right? Do not put your thumb in the juice going on there, okay? That's just wrong at so many levels. Not good. Don't do that. This was a great exam question. It's an adult. Is peeling sheets of skin. That's TEN. That's toxic epidermal necrolysis. Let's show you some more pictures. Here you go. Adult, peeling sheets of skin. TEN. All right? So remember, erythema multiforme is mild, Stevens-Johnson is worse, and TEN, peeling sheets of skin. Pretty simple. Let's do the next one. Staph's skin syndrome. This is a little kid, small kid, usually under the age of 2. For some reason, it's got some staph going on in their body where it's making this exotoxin. And this exotoxin causes cleavage of the skin in the exact same places in TEN. So they get peeling skin also. And they would also have a positive Nikolsky sign also. Okay, but the difference is it's a young kid, And they tend to do better. The prognosis of this is actually fine, okay? They do better, unlike these adults with TEN. So this is a young kid, under 2, staph, exotoxin, cleavage, just like TEN, the skin peels off, and crusting and peeling, and Nikolsky sign. Here you're going to give them some vancomycin because you're trying to get rid of the staph, okay? But better prognosis. This isn't the best picture of it. Okay, I'm going to show you a better picture in a minute. But this is a kid. They've got some crusting. You can see it. Imagine this like all over the body. I see a lot of yellow honey color here, so that makes me think about impetigo, secondary infection like that. That's why it's not the best picture for this. This is a good picture. Young kid, definitely under the age of 2. Even I can tell that, all right? Peeling skin all over. That's staph scalded skin syndrome. So when we see the peeling skin, if it's an adult, think TEN. If it's a small kid, think about staph scalded skin syndrome. All right, the next 2 things I'm going to tell you about, take a deep breath. They're called pemphigus vulgaris and bullous pemphigoid, all right? And I know you're thinking like, Peter, just kill me now, okay? It's the end of the course. Are you serious? But we'll try to make it simple. It's not that bad. What these are, this pemphigus vulgaris and bullous pemphigoid, they are both autoimmune disorders that both give big bulli, okay? So these are in adults, the autoimmune disorder, they get these big bulli. One of them is bad with a worse prognosis. One of them is more chronic and benign, okay? But they're both autoimmune, bulli. One is bad, one is more chronic and benign, okay? That's what these things are. So let's go through it real quick. The first one we're going to talk about is pemphigus vulgaris. Vulgar. Oh, that's bad, right? This is the bad one. And I know people who know Latin, that's not what it means. But okay, vulgar, vulgaris, this is the bad one. So pemphigus vulgaris. It's painful. Things are bad or painful, right? It hurts, right? So this tends to be more of a middle-aged person. So they're 40 to 60 years old, middle-aged person, who's developing these big bulli that oftentimes can start in the mouth. And again, oral lesions, those are never good either, right? It's just like Stevens-Johnson's. That's not good, right? Things that start in the mouth. So it's painful. You may start in the mouth. You get these bulli. And guess what? There's cleavage that make the bulli in the exact same place as TEN, which is also bad, by the way, right? So it's like TEN. So these are very thin bulli. So they pop real easily, and they would have a positive Nikolsky sign on top of them. Because you've got these big, thin, fragile bulli, they start to peel. It's just kind of like TEN shaped as bulli, if you think about it that way, right? That's kind of what's going on here. So pemphigus vulgaris is the bad one. Can have oral ulcers, can be painful, thin bulli with a positive Nikolsky that pop real easy, all right? This can be lethal, all right? These patients get admitted because they're sick. All right, this is pemphigus vulgaris. These are bulli. Imagine it being a little bigger. It's hard to tell on the slide, right? But imagine a decent-sized bulli. And look how thin it is. One of them's already popped, right? One of them already popped. So these are thin bulli that go with pemphigus vulgaris. This is a great picture of it, right? This looks like TEN, but it's not sheets of skin. It's bulli of skin, right? It looks like a big bulli, right? So this is pemphigus vulgaris. Thin bulli, breaking easily, bad prognosis. You can look at that. You know that's bad. You can see that that's the bad one, right? Makes a lot of sense. That's pemphigus vulgaris. Bullous pemphigoid, again, autoimmune, again, bulli, but this one's more chronic and benign. These patients tend to be a little older. They're usually over the age of 60. They may be on Lasix, is one you might want to circle as something that can be associated with it as a medication, okay? Elderly patients are on diuretics, no big surprise there. They don't have any oral ulcers, because this is not the bad one. These things just start, on the extremities, for example, large bulli, 2 to 5 centimeters, but they're probably not going to have the mucous membranes involved. And the Nikolsky sign is going to be negative, because the cleavage plane is further down. So these are thicker bulli. They don't want to pop quite as easy, that sort of thing, okay? And their course is more benign. It's more of a chronic thing going on. This is bullous pemphigoid. Again, big bulli, but these look different, don't they? I mean, they look thicker. They don't look like they want to pop. They don't look like a second-degree burn, that you're going to send to the unit or something like that going on. This is a chronic eruption in elderly patients on Lasix, bullous pemphigoid. All right, so again, just contrasting these two. And look, we all know in medicine and life, there's some overlap. They don't look like exactly perfectly distinct, right? But here's the idea. The pemphigus vulgaris, which is the bad one, you have these very fragile blisters that want to pop. They're painful. It can be lethal. You have the positive Nikolsky. Versus in bullous pemphigoid, it's a little thicker. And so because of that, they can be tense, right? Because the other one wouldn't be tense. It would just pop. So they have tense, larger, thicker blisters, more chronic, more benign, negative Nikolskys. Okay, so now we know those. We can get those questions right on the exam if they want to pop up on us. Let's do some skin cancers, all right? Let's just whip through the skin cancers, give you some factoids about this. So basal cells are the most common skin cancer. If you're going to look at a basal cell, right, it's this kind of elevated lesion. It's got this kind of like pearly appearance to it. It's got a rolled border, almost like you took pizza dough and kind of rolled it up. I'll show you a picture in a minute. Kind of rolled up border, kind of pearly look to it. Oftentimes, it will have a central ulceration on top of the basal cell carcinoma. Basal cells don't metastasize; they're slow growing. You basically just got to get them out. That's the main thing you need to do. Basal cells will only occur where there are hair follicles, so you're not going to see, a basal cell on your lip, unless you got a hairy lip, I guess, or on your tongue or things like that, right? You can see squamous cells there, but not basal cells. So it's where there are hair follicles. Slow growing lesion. This is a great picture of a basal cell carcinoma. You see the pearly look. You see the kind of rolled up pizza dough almost like appearance to it kind of at the edges there. You see a little bit of central ulceration. Another hint, if you look over the top, sometimes you'll see these little telangiectasias, little branching small blood vessels. See those little things? Look at those little telangiectasias going on there. That's another hint for a basal cell carcinoma. So this is a great picture of a basal cell. Even I could make that diagnosis by looking at this one. Okay, that's a good one. That's a basal cell carcinoma. This one's a little harder for me, but again, it's kind of rolled up a little bit of pearliness to it, central ulceration on the face where there would be, where there'd be hair follicles. That's a basal cell carcinoma. Now, melanoma, as you know, are the least common, but the most lethal. These are the ones we always worry about. They're seeing more and more of them. Risk factors are obviously, as you're an adult, if you had a dysplastic nevus that turns into a melanoma, family history, fair skin, being nice and pale like me, right, is a risk factor. Having lots of UV exposure, multiple, peeling burns as a child, all those sorts of things. You know about that with melanoma. These are the ones that are the most lethal. You remember that the deeper it is, the worse the prognosis, because these can metastasize. Tends to be in sun-exposed areas as well, right? The melanoma is there. All right, let's look at some pictures of melanoma. Remember that melanomas are very irregular. They're irregular in color. They're irregular in topography. They're irregular in their shape. They tend to be bigger than 5 millimeters, so bigger than the eraser on a pencil. Think about it that way. So your melanomas tend to be not this little tiny dot, but bigger than a pencil eraser, that sort of thing. This one's totally irregular, right? You got some flat, you got some raised, the edges are irregular, you got some darker, you got some brown, you got some all different colors. That's a melanoma. This is another melanoma. This is a classic picture of it's called a superficial spreading melanoma. Again, look at the irregularity. You got pale, you got light brown, you got darker brown, you got raised, and you got flat, you got irregular edges. We have to make sure that we do not lose these patients to follow up when we see them in the ED, right? You see somebody with something that looks like this, or you think might look like this, make sure they get followed up. We want to get this one diagnosed. So that's melanomas. And so if basal cells are the most common, and if melanomas are the least common but lethal, this is the middle, okay? It's squamous cell carcinoma. This is the middle one. Second most common skin cancer. Again, sun exposure, maybe elderly patients, elderly male would be classic, in sun-exposed area. Maybe have a lesion on the face or on the hands where they've been working out in construction in the sun all their life or something like that. Face, lips, tongue, you can have as well, right? Hands. These do grow. These can metastasize. So squamous cell carcinomas can metastasize. So again, we like to deal with these things early if we can. You can take them out. They can use, radiation. They can use 5-FU. They can use lots of different things for squamous cells depending on how big they are. So elderly patient here, they got a skin cancer, they got a growth there, there's some central ulceration on this one. It doesn't have quite the same rolled border as we saw with the basal cell carcinoma. But it's hard, we're not dermatologists, we're not going to maybe just tell them completely apart, but we'll make sure that they get followed up. This is a squamous cell carcinoma, not as pearly. It's got the border of it doesn't seem rolled up at all. It's kind of pretty smooth right around the edge. And the top, it looks like it's growing squamous cells, right? It looks like it wants to grow a fingernail or a horn or something on top of that. So that's a squamous cell carcinoma going on there. All right, so those are the skin cancers. Now you know all three of them. You know the important differences, how to identify them, and what the test questions could be for those. Let's talk about tinea infections. These are dermatophyte infections, right? You've seen these before for sure. Tinea capitis, that's at the scalp. Tinea barbae, or the beard. Tinea corporis, which is ringworm on the body. Tinea pedis, the athlete's foot, where it's all itchy, and tinea cruris, the jock itch, right? So just a couple factoids about these. Remember, tinea capitis or barbae, they tend to have broken off hair. You tend to have alopecia, some hair loss in that area. So it's scaly, it's itchy, that sort of thing, right? Remember that kids, when they get bad tinea capitis, can develop that thing called a carrion, K-E-R-I-O-N, the carrion. It's that big boggy mass. It's a big old boggy mass. It's not an abscess. Don't IND it or anything like that. It's just an inflammatory reaction going on to the bad, tinea capitis going on there. All right, so that's tinea capitis and barbae. Corporus is ringworm, right? It's on the body. I'll show you what it looks like. It's basically an annular lesion with a raised edge that just kind of spreads and goes further and further out. Again, I'll show you a picture. It's easier to look at. Tinea pedis, you know about between the feet. Tinea cruris, which is jock itch on the thighs, inner thighs, and groin, but not the scrotum, okay? You should not have this involving your scrotum. If your scrotum is red and warm and tender and things like that, think about scrotal cellulitis, or think about Fournier's gangrene if it's a necrotizing infection. But this stuff is just on the inner thighs. So these are dermatophyte tinea infections. They're caused, you don't have to memorize these, they're caused by, trichophyton and microsporum and epidermophyte. There's all these dermatophytes. Dermatophytes cause this. And you treat them with antifungals because they're dermatophytes, right? So you can use topical. Usually, the general rule is if it's on the skin, you can use topical, but if it's on the hair or it's in the nails or things like that, you need something oral, all right? But it's the antifungal sort of things for the dermatophytes. Let's look at some pictures. Okay. Tinea capitis. I know you've seen this, right? You got some scaling, you got a big old patch going on there in the back of the hair, you got some hair loss there. That's tinea capitis. Tinea corporis, you can totally see why it's called ringworm, right? Look at that red lesion, the edge is nicely raised there. It kind of just gets bigger and bigger and bigger and starts spreading out slowly. That's tinea corporis. These are all dermatophytes. There's tinea cruris involving the inner thighs. Do not panic, that is not a blue scrotum, okay? So again, should not involve the scrotum at all, just the inner thighs, very itchy, tinea cruris. Those are your tinea infections. Now, I hate when this happens, but this is just the truth. We all learned about tinea versicolor, but a better name is actually pityriasis versicolor, because it's not a tinea, okay? It's not really a tinea. This is not a dermatophyte infection like the ones I just told you about, okay? It's actually associated with mollusacea, that fungus that causes dandruff, right? That causes seborrheic dermatitis. So even though we all learned it as tinea versicolor, it's not a tinea. Think about it as pityriasis versicolor, okay? This is a rash associated with mollusacea fungus, okay? Just like dandruff is. What does this look like? I'm sure you've seen this before. It's like these hypopigmented, sometimes hyper, but oftentimes hypopigmented, little patches or macules. They tend to have just a little bit of very fine scale on it. You'd have to look real closely. But basically, you're just examining somebody's lungs. You got the gown open and you're listening. You're like, hey, what's all that stuff on your back? And you ask them, like, hey, what's that stuff? They're like, oh, I don't know. Yeah, I've been noticing those things, but it's not really bothering me, okay? There's not that much that goes with it. It might be a little bit of itch maybe, but not much, right? So it's basically these kind of like hypopigmented patches. It's not a tinea. It is associated with mollusacea. So guess what? You treat it like dandruff. Because it's the same bug associated with dandruff. You treat it like dandruff, okay? So here we're going to use, your selenium shampoos, your ketoconazole shampoos, those sort of things. So they can just get the over-the-counter stuff and wash it on their body, leave it on 10 minutes and wash it off, repeat, that sort of thing, right? So that's pretty much it. That's pityriasis versicolor, hypopigmented stuff on the trunk. It's associated with there's like a lot of moisture. They leave their basketball shirt that they play in every day in their gym closet over and over. This is gross, right? Don't do that. And there's fungus growing on that, this mollusacea. Okay, you got to wash the clothes. That is pityriasis versicolor. Okay, we're going to take a little twist here. Talk about some spirochetes. Do some interesting things here. Who here has seen leptospirosis? 1, 2, 3, 4. Where did you see it? What state was it in? Puerto Rico, okay. Where else? Guam, Hawaii, Haiti. All right, so you're kind of getting some concept here, right, about the sort of climate where this may be seen. It can be seen in lots of different places, but in the U.S., about half of the cases occur in Hawaii, all right? So if they give you Hawaii in the stem of the question, I'm already thinking about leptospirosis as one of the possibilities, right? So what's the deal with this? Leptospirosis is caused by a spirochete. So imagine that you are in Hawaii on your Hawaiian vacation, having a good old time. You go out hiking, and you want to go hiking where nobody else has been. You want to find a beautiful freshwater pool to take a swim, all right? And you go and you find some hiking trail, and you go hiking up, and you find this beautiful fresh water where you're like, no one's been there. This is great. I'm going to go. And you take off your clothes, and you go for the swim and all that sort of stuff. Well, unfortunately, somebody has been there before you, okay? And the somebody were rats, cattle, pigs, or dogs who peed in the pond, all right? That's what's going on. So this is coming from the urine of the cattle or the urine of these pigs and dogs, things like that, where they get the spirochete into fresh water. And you go swimming, and the spirochete goes through your skin, and now you've got leptospirosis, okay? So that's how you get this. So fresh water, whitewater rafting, swimming in the fresh water, things like that. Okay, those would be kind of the hints in the stem of the question of how this person may have acquired this. Infected water from animal urine, essentially. Okay. The spirochete, all good spirochetes disseminate, right? That's like the job of a spirochete is to disseminate. So it goes in through your skin and it starts disseminating throughout your body. And the things to remember, if you're going to remember leptospirosis, are hepatitis and nephritis. It affects your liver, it affects your kidney, okay? So you're going to have hepatitis with elevated LFTs, you're going to have nephritis going on, things like that. You can get other things as well. Something that's called Weil's disease, which is originally described in sewage workers, is where they were getting this infection from. It's just bad leptospirosis, really sick patients, liver involvement, kidney involvement, meningitis. They get a leptospirosis meningitis, coagulopathy, DIC, right? Bad things from disseminating spirochetes. Hepatitis and nephritis is the ones to remember, and they die of hepatorenal failure. That makes sense. There's a serology test you can do for leptospirosis. The treatment is down here. I think that would be a stretch to ask you on the EM boards, but it's down there for your information, okay? So that's leptospirosis. Another spirochete we need to talk about, of course, is Lyme disease, and we've talked about this multiple times throughout the course in different sections. But, why does Lyme have its name? What's it from? Lyme, Connecticut, right? So it was, what was it? It was the 1970s. There was a cluster of kids who had really bad arthritis, and they thought it was juvenile rheumatoid arthritis, right? They're all living, like in and around like Lyme, Connecticut, this area is there. And they're like, why would there be a cluster of juvenile rheumatoid arthritis? That's not contagious. That doesn't make any sense at all, right? So as they investigated it, they figured out it wasn't JRA. It was this new disease that they had figured out, right? It was Lyme, right? So it's Borrelia burgdorferi. Borrelia is the spirochete. Remember, it's from the Ixodes tick, the deer ticks is what's going on. So you got a bite from the Ixodes tick. You get Borrelia burgdorferi, gets into your body, right? You get fever, myalgias, like usual viral type of stuff, right? And then you get the 3 stages: the rash, the erythema migrans, the dissemination, where you get neuro and cardiac stuff, and the persistent arthritis, which is where they were picking it up in these kids. That's where they started discovering it. Again, erythema migrans, since we are in a derm lecture right now, this is a rash that occurs where you got the tick bite. So you get the tick bite, and you get this red rash that starts spreading out, right? An annular lesion that starts getting spreading out. It can get central clearing. It doesn't have to have central clearing, but you can have central clearing as well. It tends to not be on the palms and soles because you don't get a lot of tick bites on the palms and soles, okay? You can get multiple lesions from multiple tick bites, and you can get it from secondary dissemination to the skin, but it's just less common, okay? But it's where the tick bit you got the rash going out. This used to be called erythema chronicum migrans. Remember that? They got rid of the chronicum. So it's erythema migrans, red rash spreading out. Then you get your dissemination, neurologic things. We've talked about some of these, right? You can get a Lyme meningitis. You can get cranial nerve 7 palsy. If you ever see bilateral cranial nerve 7 palsy, go directly to Lyme disease as the answer. Cardiac, myocarditis, pericarditis, heart block. A young patient comes in your emergency department and heart block. Don't see that every day. Think about Lyme. Okay, diagnosis. Again, it's almost like HIV where you do an ELISA screen and a Western blot confirmation, that sort of thing is the testing. Treatment for this, doxycycline. You can also use amoxicillin. There are other things you can use as well. But doxy, if I were going to remember one, is the one that I would remember. Okay, doxycycline for Lyme disease. There's some stuff down here about testing. It can be very confusing. I'll just make a few points about testing for Lyme. The first thing to realize is that when you're in that first stage where you have the rash, testing is not very sensitive, so it's not very reliable. So the point of that is if you're living in an area and you see that red rash, don't bother testing, just go ahead and treat empirically because the test could be wrong. It could be a false negative. All right, so if you think they got it, go ahead and treat it. That's the first point to do. Now, as they get later on in Lyme, secondary, tertiary, those sort of things, the test starts to get more sensitive. It's still not perfect, maybe 85, 87, 90% sensitive, but it gets better later on, but early on it's very insensitive. The only other point I want to make about Lyme testing, not tasting, don't do that, Lyme testing, is just like other things, if you were to test a low-risk population, if we just took everybody and started testing them for Lyme, we're going to get some positives that are probably false positives, right? Because it's not a perfect test. And it's more likely to be a false positive when you're just screening people. And that's why you don't want to do it as just screening tests for totally low-risk people. All right, so that's Lyme. And again, we've talked about this stuff a bunch. There's Lyme, erythema migrans, got bit in the middle, annular rash, moving out, red, now pale in the center. That's erythema migrans. Another picture of erythema migrans, hasn't cleared in the center here yet, but absolutely erythema migrans with Lyme. More Lyme. Sometimes they can get necrotic in the center, but not usually. There's Lyme. Okay, meningococcemia. Let's talk about this one. Again, you know this stuff. This is Neisseria meningitidis, a little encapsulated gram-negative diplococcus, caused lots of bad disease, a spectrum of disease. Remember, you can have meningococcemia, which is the infection in your blood. You can have meningococcal meningitis, where it's just meningitis, or you can have both, right? So sometimes people confuse it. They're different things, right? You can have meningitis, you can have meningococcemia, or you can have both going on at the same time, all right? Broad spectrum of disease. Again, fever, headache, myalgias, and then they get the rash. The little small petechiae, those little small petechiae that start to develop into purpura, and then they start to coalesce and get really bad purpura, and then basically you get bad, essentially an infectious vasculitis where you start to knock off end organs everywhere, right? Knock off, kidney and liver and, digits and extremities and things like that. Bad stuff going on from meningococcemia. Poor prognosis from meningococcemia. Well, first of all, it's not good just to have it, all right? But when you do have it, not surprisingly, if you're hypotensive or highly febrile, those are not good things. You want a good white count when you have meningococcemia. You'd rather have a white count of 30,000 than 5,000, okay? 5,000 is bad with meningococcemia. 30,000, I'll take it. It means you got your immune system is doing better, okay? So it's actually better prognosis with a good white count. What about prophylaxis? All right, so this stuff is transmitted through the secretions, right? Through the secretions and the droplets with the secretions going on there, secretion contact. So, obviously somebody who lives with somebody with meningococcemia is going to get prophylaxis. If you're intubating or suctioning somebody in the emergency department, absolutely you need prophylaxis. If you've been working with somebody for a while who has meningococcemia, you should get prophylaxis. This is not like chickenpox, though, okay? This is not like where you walked by the room, and you caught it, okay? That would be really, really unlikely. You got bad odds. You got a better chance of probably winning the lottery, all right? So that's not the way this usually works. And how do you do post-exposure prophylaxis? And by the way this always happens, right, is you're working a shift, you're taking care of somebody, they go upstairs, and then you get the call, right? You get the call from the ward upstairs. They go, hey, we just wanted to let you know that patient had, meningococcal meningitis. Have a nice day, click, that sort of thing, right? You're like, seriously? I was with that patient, for hours, and everybody in your emergency department freaks out when that call happens, right? Reliably, everyone freaks out. They're like, oh my God, I got a headache, I got neck pain, I'm already feeling it, like immediately. Everyone starts freaking out and they think they got this stuff. The good piece of news, and this is just for your own knowledge, not for the test, if somebody lives in the house with somebody who's got meningococcal meningitis, for example, what is their chance of actually catching it? They're living with them, right? Chickenpox, it's really good chance, right? But somebody living with them, it's about like 1 in 250. All right, so this is not like highly contagious. It's not like, oh my God, this is like highly, highly contagious. It's contagious. You want to get prophylaxis if you've been spending time with them, but no need to totally freak out about this. Post-exposure prophylaxis, you could do rifampin for a couple of days, or you could just do a single dose of P-O-Cipro. All right, so if they're not allergic to it and they're not pregnant, I guess if they don't have tendon issues, 1 dose, 500 milligram P-O-Cipro, and you're done with it. So when you get the call, you just say, okay, anybody not pregnant and not allergic to Cipro, it's like Pez, here you go, okay, back to work, we're done. All right, here we go. Okay, And again, you know, blood cultures, CSF cultures, treatment with high-dose pen or chloramphenicol for meningococcemia. And don't forget about our friend Waterhouse-Friedrichsen syndrome. So this is where somebody's got meningococcemia, bad day to start, and now even worse day, they have bilateral adrenal hemorrhage because of infarction, okay, from meningococcemia, right? That's a bad thing, that's meningococcemia. I really encourage you when you're examining patients, particularly febrile kids, you know, we always document no rash. You know what I do? I go no rash, no petechiae. Because frankly, I want people to know that I actually thought about it and looked for petechiae. Really, really important in these kids, right? Because they can start looking pretty decent with just a couple little petechiae, and then they come back with florid meningococcemia. So you got to look closely, and you got to document no rash. Of course, if there is no rash, all right? Okay, here's some meningococcemia, some petechiae, some purpura. Those are probably going to be some palpable purpura because it's an infectious vasculitis. That's meningococcemia. You wouldn't know just from looking at it, but if they tell you this patient is febrile, go meningococcemia. And this is what it can turn into, right? So this is why we got to be really careful and make sure we pick it up early. That's bad. Okay, I think let's take our 15-minute break. Does that sound good? 15 minutes, we'll come back and we'll finish. See you soon. Okay, back to work. Here we go. All right. Okay, now we're going to do part 2 of dermatology. Let's just knock this thing out, finish it up. And I'll keep the pace going quickly so we can get out of here. Necrotizing soft tissue infections. You know about these? These are the flesh-eating bacteria, right? All the things you read about in the Journal of the National Enquirer, right? Flesh-eating bacteria ate my aunt, that sort of thing, or something like that, right? Right, so there you go, right? So these are virulent toxin-producing bacteria, often seen with intravenous drug use, but lots of different things can do it. You can have an anaerobic cellulitis, myonecrosis, necrotizing fasciitis, right? Necrotizing fasciitis, we get rapid dissection across the fascial planes. You all have seen and know about that. Again, pain out of proportion to exam would be classic with that. You know, I got a little infection that started down here, but boy, I'm kind of tender all up here. It's because it's spreading along the fascial planes. Pain out of proportion to exam, ecchymoses, things like that going on. Necrotizing infections are surgical emergencies. They're infections, so of course we give them broad antibiotics, but they are surgical emergencies. You have to get a surgeon involved, document it early on your chart, get him involved early when you think someone has a necrotizing soft tissue infection, all right? Broad spectrum antibiotics. We talked about Fournier's gangrene, which is basically necrotizing fasciitis of the scrotum in men or the vulva in women, perineal area. You oftentimes have gas with necrotizing infections. You can see the sub-Q air on the x-ray there, pretty straightforward. Those of you who like to use ultrasound, you can see all the air on the ultrasound, real easy to do. You can see it on your CT scan, right? You see some air tracking up the patient's thigh there. These are those necrotizing soft tissue infections. Surgical emergency. MRSA. MRSA, remember some of you have been around, you know, MRSA used to be just this hospital-acquired thing, right? There wasn't community MRSA. And it was almost like a special thing when a patient with MRSA came. It's like, oh, they're coming in, they've got MRSA, right? They were dialysis patients or hospitalized patients or things like that. But now we know that there's community methicillin-resistant Staph aureus all over the place, and a lot of the skin infections we're seeing, all those, you know, some cellulitis and some furuncles and abscess and all these things, a lot of them have MRSA now. You know, it's methicillin-resistant Staph aureus, so it's not, will not work with the usual primary antibiotics that we would use, right? You can't use the primary line antibiotics. You have to use things that are, the beta-lactams will not work. You have to use broader things, right, for MRSA, as we know. We do this all the time. Mild infections, you use things like doxycycline, clindamycin, trimethoprim sulfa, things like that, right? For more serious infections, you can use vancomycin, you can use linezolid, there's some quinolones you can use as well, but basically different guns. You can't use just the usual stuff. You can't just use, like, you know, your Keflex and things like that, or your dicloxacillin, things like that. It's not going to work. Okay, you've seen it, so we'll go through it quickly. All of these things are MRSA. Lots of community-acquired stuff, lots of MRSA. Cover MRSA. Toxic shock syndrome. We don't see this that often, so it's good for the boards, right? You remember how this happened? Remember the initial description was in women who had tampons in. These tampons got colonized with Staph aureus. The Staph aureus made an exotoxin, and this exotoxin caused badness. It causes bad toxic shock syndrome. And the way I remember it for toxic shock syndrome is they got fever, so they're toxic. Right, there's your toxic, this fever. They got shock, which is hypotension. And then they got syndrome. And syndrome is they got a red rash and multi-organ involvement. That's what's going on. Okay, so they're toxic, they're febrile, they're shock, they're hypotensive, and they're syndrome, which is they got diffuse red rash, you know, nothing really perfectly diagnostic of the rash, diffuse red rash, and a bunch of multi-organ involvement. That's toxic shock syndrome. They're pretty sick, all right? Treatment, fluids, get rid of the source, right? Get rid of wherever the staph is living, get them on antibiotics. And of course, it doesn't have to just be a tampon. It can be anything where there's, you know, packing, right? Wound packing, nasal packing, any of those sorts of things where you can get staph colonization going on there. You got to get rid of the source, give them on antibiotics. One other factoid to tell you for the exam. There is a strep variant of toxic shock syndrome, and so it's a strep toxic shock syndrome, and the only thing to know about that is it has a higher mortality than your usual staph toxic shock syndrome, okay? So strep, higher mortality. All right, let's do some tick-borne stuff. Rocky Mountain spotted fever. Who's seen this? Bunch of people. All right, yell out some states for me, please. Where you had it? Kentucky. North Carolina. Arizona, where are the Rocky Mountains? What's going on here, right? What's going on here? So Rocky Mountain spotted fever. Okay, so this was actually first described in the early, I think it was the 1900s, by a guy named Dr. Howard Ricketts in western Montana, Rocky Mountains, western Montana, where these patients were getting what they thought was he called the black measles, was what they called it back then, the black measles. And they thought they were getting it from drinking the melted snow, is what they thought was going on, all right? So Dr. Ricketts described this. And in the Rocky Mountain lab, they also identified this little bacteria called Rickettsia rickettsii, which they named obviously after Dr. Ricketts, like Ricketts, right? Rickettsia rickettsii. So it's this little bacteria, it's a little bacteria that you get from a tick bite. And it can occur in lots of different places, but it's endemic to the southeastern United States, right? So the North Carolina, that would be a great one to put into the stem of a question if you're going to ask about Rocky Mountain spotted fever. So you can see it in lots of places, but the southeastern United States is where it's now endemic, all right? These are ticks, and it tends to be young kids, right? So these are kids under 15 in general. So these are kids, they're out playing with the ticks in the spring and the summer. So that's when it happens, when there's spring and summer and there's ticks and kids are out playing with the ticks, all right? They get their tick bite. They get your fever, headache, myalgia, the usual stuff. And then they get these small pink little macules that turn into like little petechiae, and some of them can turn into purpura. They start distally, peripherally. So they start on the feet and the ankles, and they start on the hands and the palms and the wrists and things like that. And then they work their way in. So they start out and they work their way in is what happens with Rocky Mountain spotted fever. It's not on the face. This is like an extremity and up to the trunk thing, but you're not getting spots on the face, okay? Think measles with that, right? But this is coming up to the body. If you were to do labs on them, white cells is normal, no problem with the white cells. Low platelets, so they're going to have some thrombocytopenia. That's one to kind of circle and remember, I would say. So they have some thrombocytopenia with them. This is a clinical diagnosis. You can send off serology tests, but you got to make a clinical diagnosis. You got to start treating them immediately, and doxycycline is what is preferred. And I know we tend to avoid doxy in kids, but if they got Rocky Mountain spotted fever, you give them doxycycline. Okay, so doxycycline is the answer for this one. This basically turns into a vasculitis, right? It's an infectious type vasculitis, and vasculitis just picks off end organs. So you get all sorts of end organ complications, all right? So a kid playing with the ticks in the spring and the fall, they get viral symptoms, they get the rash that starts distally, it works its way in, they got some low platelets, treat them empirically with doxycycline. That's Rocky Mountain spotted fever, and endemic in the southeastern United States. So here's the kid, got bitten by a tick, now he's got, look at these little petechiae, little spots all over the palms and the wrists. Ooh, and look, it's progressing proximally and now moving up their arm, that sort of thing, and the rash is moving up to the trunk. That's Rocky Mountain spotted fever, pretty straightforward. Ehrlichiosis, simple, okay? It's spotless, Rocky Mountain spotted fever, okay? Spotless, Rocky Mountain spotted fever. That also messes up your white cells. If you know that, it's done, because it's the same sort of thing. It's a tick bite again. This time, the little bacteria will also infect your white cells, which is why you get a white cell problem. They also get fever, headache, myalgia. They also get a rash, but they don't get the classic spotted rash. They just kind of get this, red maculopapular nondescript sort of thing, all right? So it's spotless, Rocky Mountain spotted fever. They also have thrombocytopenia, just like Rocky Mountain spotted fever. But they also get leukopenia, because remember I told you this one will infect your white cells too. So it's spotless, Rocky Mountain spotted fever, with low white count because your white cells are involved. It's also clinical diagnosis. It's also treated with doxycycline. It also is the same complication. So it's basically the same thing, all right? That's ehrlichiosis. Pretty straightforward. Doxy. Okay, how many of you seen babesiosis? Yeah, some of those, yeah. Where were those? Curious. New Jersey? Where was yours? Connecticut? All right, yeah. So this is an interesting disorder. I've never seen this one. It's really interesting because I practice out in California. But this is kind of, I think about this as New England's version of malaria, but instead of being a mosquito, it's a tick, okay? That's kind of the way I think about it. It's like New England malaria, but it's not a mosquito-borne, it's a tick-borne. So what this is this is a tick-borne disease where you get bit by the tick. You're hanging out there in New England, you get bit by the tick, but you get a little protozoan who lives inside your red cells, just like malaria, okay? Little protozoan living inside your red cells like malaria. And you get fever, chills, myalgias, hepatosplenomegaly, jaundice as you're popping some hemolysis of these red cells, that sort of stuff, right, going on, right, that sort of thing. And just like malaria, if you did a blood smear, right, thick smear, thin smear, all that sort of stuff, you could see the little parasites hanging out in the red blood cells. Okay, so it's like New England's malaria, but instead of a mosquito giving it to you, it's a tick that gave you these parasites inside your red blood cells. The other thing that's a little different than real malaria, of course, is that these patients tend to do pretty well. It's not that severe of an illness in general, unless if you're immunocompromised or if you're asplenic or you're elderly, this can be a really severe infection. But young, otherwise healthy patients, they tend to do pretty well. Oftentimes they don't know they even had it. That's what it was, I should say. They got sick. It kind of felt like a viral illness, and it cleared itself on its own. They don't even always treat this. Sometimes they'll pick it up in a blood donor or something like that, and if they're totally asymptomatic, they'll even watch them and say, well, okay, if it doesn't clear after 2 or 3 months, we'll start to treat you. So it's a much, it's not a severe disease unless you're elderly, asplenic, immunocompromised. Treatment, it's written down here. Again, I don't think they'd probably ask you that on the EM boards, but it's there for your reference. So tick-borne little protozoa inside your red cells. You can pick it up on a smear. They don't do that badly unless you're elderly, immunocompromised, or asplenic up in New England and that area. Okay, let's do some viral infections. CMV, I know that this has been covered already before, so I won't spend a lot of time of it. I will mention that it is the C in the torches infections. Remember, torches are the ones that cause bad congenital infection. So if you're a fetus, you do not want a torch infection going on there, right? And it's down at the bottom there in the box, the toxo, rubella, CMV, herpes, that sort of thing. And the O is for other. I hate that. Other, right? Come on, really? But anyway, there's lots of other ones. Bad congenital infections. For normal patients, if we get it, it just feels like mono or something like that. But if you're immunocompromised, you get all the bad things that I know you've already heard about: retinitis, nephritis, pneumonitis, colitis, that sort of stuff. They may have atypical lymphocytes, gangcyclovir or foscarnet. So in gangcyclovir is what you want for CMV, or if it's mild, they can use like a valganciclovir orally, stuff like that. But basically gangcyclovir for CMV. This is a really unfortunate example of intrauterine infection with congenital CMV. You can see, looks malformed. You see the outline of the liver and the spleen there, just not very good. This is also CMV. I wouldn't know that by just looking at it, to be honest with you, but apparently this is CMV going on there as well. Maybe they have a CMV colitis as well involved with this further in, I don't know. Herpes simplex. Herpes simplex, again, type 1 above the belt, type 2 below the belt. The key thing with herpes simplex, diagnosing it, is painful grouped vesicles. Whenever you see a bunch of painful grouped vesicles, think about herpes simplex virus, okay? If it's in a dermatomal pattern, think about zoster. But other than that, grouped painful vesicles, herpes simplex virus. And type 1 gives you herpes stomatitis in the mouth. It gives you the corneal ulcers that you can get. It's why we do the fluorescein staining, looking for the dendritic pattern. Herpetic whitlow on the finger with the painful things on the finger. Type 2, below the belt, right? Genital infection, right? Sexually transmitted infection, things like that. Genital, anus, that sort of thing. Pharynx can get it as well. Diagnosis, viral culture or PCR. Herpes encephalitis is really bad. It's sporadic. It can occur in patients of all ages, right? So you just got to be thinking about that. Patients who are altered, infected, you think they got meningitis, but maybe they're seizing or something like that too. Think about herpes encephalitis. And you treat herpes infections, herpes simplex infections, with acyclovir or those analogs, right? Valacyclovir, things like that. Okay, this is herpes simplex virus. Now, I got to be honest with you, this is not a place that I normally would think I'm going to see a bunch of herpes simplex virus. But when I see painful, grouped vesicles together, I go with herpes simplex. And I wonder if this is a little eczema herpeticum, if this person didn't have a little bit of, at least I try to imagine, maybe they had some, some eczema going on there first and they got this right on top of it. I don't know. But grouped painful vesicles, go with herpes simplex. Grouped painful vesicles on the finger, herpetic whitlow. Grouped painful vesicles in the genital region, right? And again, when we say vesicles, they start as a vesicle, but they pop, right? So it's like a little popped vesicle now we got going there. That's obviously genital herpes there. If you have a young woman who comes into your emergency department with new urinary retention, think about doing a pelvic exam. This can cause that, right? Very painful and can cause acute urinary retention as well. So it's important to do some history and exam on that as well. So genital herpes, you know about this. Okay, zoster is shingles, right? We know about shingles. Remember, you started with chicken pox as a kid, or at least we used to. Varicella zoster virus. You got chicken pox. Chicken pox goes away, and it hangs out in the ganglion, right? The virus hangs out, and then as you get older, it comes out. It comes back in again. And you're basically kind of like getting chicken pox in one dermatome. Think about it that way, right? So if you're normal immune system, it's coming out in one dermatome. But if you're immunocompromised, you can have multiple dermatomes. You can have disseminated zoster, and those patients are obviously sicker, right? It can occur in any dermatome. It doesn't have to be, it could be cranial nerve, thoracic, lumbar, any of those sort of things. Reminders, zoster ophthalmicus, which is where you have it on the face, right? You got it on cranial nerve 5 in that first ophthalmic distribution. So you got it on the forehead, painful vesicles, dermatome on the forehead. We're looking for Hutchinson sign, that vesicle at the tip of the nose, which means you have involvement of the nasociliary branch of that nerve. Naso, nose, ciliary, like the ciliary body in the eye, which means you may have eye involvement as well, okay? So that's zoster ophthalmicus. Ramsay-Hunt, it's just zoster, but it's coming out along cranial nerve 7. So it's the shingles of cranial nerve 7. So you can have a facial nerve palsy, and you can have pain and some vesicles on your exterior ear canal and things like that. That's Ramsay-Hunt syndrome. It's just shingles in a different place. Complications, probably the most common is postherpetic neuralgia, right? This stuff hurts when you get it, and when it's over, you can still have a lot of pain. It can be really debilitating, particularly in elderly patients. But there are other infections as well that you can get with it, superinfection, et cetera. Treatment for shingles is basically acyclovir, the acyclovir analogs. You can use prednisone, but not for routine cases. You use it for those like Ramsay-Hunt is where I would use syndrome, neurologic involvement, or really severe pain, bad shingles, something like that. You might think about prednisone, but not routinely. Acyclovir. These are great exam questions, my friends, okay? There's nothing else that looks like this. A bunch of redness and vesicles all together in a dermatome. That's shingles. That's it. So just bore it into your mind. You know it. Shingles in a dermatome, shingles in a dermatome. That's it. Okay, AIDS, HIV. We've talked about this at various points along the course. Obviously, we could talk for hours about this disorder. Just a couple little factoids just to remind you for the exam, just the little things. As you know, this is a retrovirus. It infects your CD4 cells. The CDC has a classification of it. Stage 0 is when you're early in infection. You wouldn't be HIV positive unless you did a PCR test, early infection. Stage 1, you're HIV positive, but you got more than 500 CD4 count, so you're doing all right. Stage 2 is when you're between 200 and 500. And then stage 3 is when you've dropped below 200. So now you have AIDS, right? So you have less than 200, or you have one of the AIDS-defining illness like tuberculosis or cocci or PJP or any of those sort of things going on, right? That's stage 3. Okay, we've talked about each of these during the course at some point. PJP, I'll just remind you that it's very, very common in HIV infection and AIDS. Chest X-ray, bilateral infiltrates, a lot of hypoxia. You treat it with trimethoprim sulfa. And then remember, you may also add on steroids to treat the PJP pneumonia, all right? And in the old days when we did a lot of blood gases, we were always taught that when you use steroids is when the PaO2 is less than 70 or your AA gradient is greater than 35, right? You guys remember that? Less than 70 or AA gradient greater than 35. But we don't do a lot of blood gases in people anymore because we don't need them and they're really painful and not fun. So a practical approach to this is I just think, well, wait, PaO2 PaO2 of less than 70, that's the same as like a SAT of 92 or less. So I just use pulse ox. So if they've got pneumocystis infection and their SATs are 92% or less, just go ahead and add the steroids. Go ahead and add the prednisone. Does that make sense? It's an easier way to do it. You're not doing blood gases anymore on these patients. And if you remember, it's like a 21-day course, right? Like they give them like, see if I can remember, they give them 40 milligrams, and they won't ask you this on the exam of like exact dosing, okay? But it's like 40 milligrams twice a day for 5 days, and then 40 milligrams once a day for 5 days, and then 20 milligrams once a day for the remaining, whatever it is, 11 days, all right? So a 21-day course. So it's a taper over 21 days for PJP. Cryptococcal meningitis, common fungal infection, diagnosed on LP, set off the cryptococcal antigen. You can do the India Ink, test if they still let you have microscopes in your emergency department. You can look at it for that. Treat it because it's a fungus, amphotericin B, and 5-FC, flucytosine, okay? Toxo, we've talked about a lot. Very common CNS infection in patients with HIV. If you see a mass lesion, ring enhancing on the CT in someone with AIDS, that's toxoplasmosis. Candida, you know about it, causes thrush, causes esophagitis, very common, you've seen that as well. Clotrimazole, nystatin, things like that. Here's candidiasis, that's, again, you've seen this stuff a million times, just quick review. If it's on the tongue, you could, it scrapes off easy with the tongue blade sort of thing, so that's oral candidiasis. Kaposi sarcoma, it's actually relatively common. It's the second most common AIDS manifestation. It's actually pretty common. Interestingly, this is only seen in the AIDS population of men having sex with men, okay? It's not seen in individuals who got their HIV infection through intravenous drug use or blood transfusion. So it's the MSM population that ends up having Kaposi sarcoma. And that's because it's associated with human herpes virus 8, okay? It's human herpes virus 8, and that's why it tends to be within that population transmitted. Okay? It's not usually a big cause of morbidity or mortality itself. It's usually just more of something they see on the skin that they don't like and are not happy to be having right now. If you remember what these look like, these are kind of like purple, painless, non-itchy lesions. They can be really flush with the skin, or they can be a little bit raised. They can sometimes have a purplish brown look to them, okay? And again, I'll show you some pictures of what this looks like as well. What these are, it's a tumor of lymphatic endothelium. So the lymphatic endothelium starts to just multiply, and then it gets filled in with blood, okay, like a little endothelium would do. And that's why it has this purple look to it, okay? It's this purple brownish look to it. These can persist, they can enlarge, they can coalesce, they can bleed. They can be outside of the skin as well, okay? You may not see it, but they can be in your GI tract, lungs, liver. They can be outside of the skin as well. Treatment for these lesions is with the HART therapy, right? These highly active retroviral therapies, the medications that we use for HIV/AIDS. And some of them can also, if they're real localized, they can use cryotherapy on them as well. So this is Kaposi sarcoma. Purple lesions. Some of these are flat. Some of these are raised. They're not, they're not painful or anything like that. They're just, you see the lesions there going on. They're not febrile. This isn't meningococcemia, etc. This is what I meant by that kind of brown, purplish look to it, right? That's what these tend to look like. These ones are flatter than the picture I just showed you. Again, this is all Kaposi sarcoma, excuse me. Okay, molluscum contagiosum. More commonly seen, or I should say common infection in young kids. So young kids, these are like young kids that get this infection. Also seen in HIV. So kind of two different populations, right? So the young kids get it as a really kind of little benign infection, and folks who are HIV positive can also get molluscum as well. Molluscum contagiosum is a viral infection of your skin. It's a pox virus. It's a little pox virus is what it is, okay? And what these classically look like is about 2 to 5 millimeters skin-colored papule, okay? So it's a little skin-colored papule. And if you look at it real closely, it has what's called central umbilication. Looks like somebody took a pencil or a pen and made a little indentation, made a little umbilicus right in the top of that little papule, all right? Central umbilication. Look closely and you will make that diagnosis of molluscum. They get this thing called autoinoculation, which is where you basically are giving it to yourself, right? So like I got it on my upper eyelid and I'm blinking, so now I have it on my lower eyelid. So where you see places where skin touches, you can get what's called autoinoculation, all right? But it's a benign little pox lesion on the face of kids would be the classic thing that will go away on its own in these kids, and it's not a big deal. It's self-limited, okay? How is it transmitted? Well, it's transmitted by close personal contact. So in kids, that means, playing with each other, swimming pools, things like that. In adults, it's also close personal contact. So it's, playing with each other, all right? That sort of thing, right? The adult play. So sexual transmission can occur in adults, all right? Again, in HIV/AIDS, it is something that you can see. The lesions can actually be very extensive. They can see a whole bunch of them, and sometimes they'll try to burn those out with the cryotherapy and stuff like that. But two different populations. Benign little thing on the face of kids, and HIV can get a bunch of them as well. Okay, this is a great slide. This is just a beautiful example of molluscum. Young kid, a bunch of little lesions, maybe even some auto-inoculation here. Some up at the top, some down at the bottom there. They look like little papules, and you say, huh, let me take a closer look. Let's take a closer look. Look at that, belly button right in the middle of it, right? Hard to hold it still, but that's it. Central umbilication, that's molluscum. Pox virus in kids, simple. All right, mono, you guys know what mono is. We see this all the time, right? Like kissing disease in adolescence, right? That's basically a kid who's got an exudative pharyngitis, right? Adolescent exudative pharyngitis. So fever, exudative pharyngitis, adenopathy, that sort of thing, that's mono. They can also get splenomegaly. Kind of hard to feel on exam sometimes. I got like stone hands, right? I never really feel it, but so splenomegaly, they can get involvement there, right? They get liver involvement, spleen involvement. Atypical lymphocytes on their smear. Diagnosis, monospot. If you want to send it off, you can do that. And then remember that amoxicillin, it's not an allergy, but when you give patients with mono amoxicillin, not that you should, but if you happen to, they will pretty reliably just develop this rash. And I had somebody at this board review course many years ago tell me, Peter, in the old days, before we had monospots, in our practice, we used to use amoxicillin as our diagnostic test. If we thought they had mono, we'd give them some amoxicillin. And if they got a rash, we were right. Okay, I'm just sharing it. I'm not recommending it. I'm just telling you, all right? So it is one of those things that you can see. And again, treating mono, rest, supportive. They shouldn't have contact sports, right? We don't want to helmet to the spleen and have splenic rupture. And here's mono. You got your exudative pharyngitis. You got your atypical lymphocytes there. And you got this rash. They got a little bit of amoxicillin. They got their nondescript rash. That's mono. Okay. Let's do some pediatric rashes next, all right? I already told you about the torch infections. But there it is again. Toxo, other, thanks, right? Rubella, CMV, herpes simplex virus, bad congenital infections. How about fifth disease? Erythema infectiosum. So this is caused by parvovirus B19. So parvovirus B19, this is going to be a young kid who comes in with fever, comes in with URI symptoms, that sort of stuff, and you look at them and they've got these red slap cheeks. And I just remember fifth disease, 5 fingers on a hand, slap cheeks, right? So fifth disease is the one with the slap cheeks. If you look at their body really closely, sometimes they'll have a little, lacy little fine rash on their body, but we don't tend to see that because we're not looking that close. And we're like looking at those red slap cheeks, all right? We look at those. But if you look at their body, they may have a little fine lacy rash there as well. These kids generally do fine. It's a viral infection, parvovirus B19. They generally do fine. They can have a little arthritis or stuff, but they generally do fine. But remember parvovirus B19, remember that if somebody has sickle cell disease, that can trigger an aplastic crisis, right, where they're not making red cells, right? So you definitely, if there's a sickle cell patient in the family, you'd like to maybe keep them away from the sickle cell patient because parvovirus B19 can precipitate that. And you remember, somebody comes in your emergency department with acute sickle cell pain crisis, we're checking their labs, right? We're always checking their CBC, and we're checking their reticulocyte counts to make sure that they actually have reticulocytes, that they're actually making enough new red blood cells to replace them, and that they don't have an aplastic crisis, right? That's the aplastic crisis is parvovirus B19. So that's an important little testable factoid here, right? Slap cheeks in these kids, parvovirus B19, so you don't want them precipitating aplastic crisis in somebody. Parvovirus B19 can also cause a fetal anemia. If we were to go back a slide, it is one of those in the other. See that? One of the other. So parvovirus B19 can cause a fetal anemia. So you want to keep them away from patients with sickle cell, keep them away from patients who are pregnant. That's it. But young kid, fever, URI symptoms, you see the slap cheeks. That's it. There you go. Kiddo came in, fever, URI symptoms, little cough, runny nose, blah, blah, blah. It's not abuse. Those are slap cheeks, but they haven't been slapped, okay? That's fifth disease. Hand, foot, and mouth. I love disorders like this. It tells me where to look. Hand, foot, and mouth disorder. This is Coxsackie virus, fecal oral transmission. And remember what this is, right? So they get the mouth part, is they get these painful vesicles, painful oral lesions in the anterior mouth. So anterior, lips, tongue, things like that. Anterior mouth. When you see that, you then look for their hands and feet. And what you're going to see there are either these kind of gray vesicles or red, kind of inflamed looking vesicles on their palms and soles, all right? So it's hand, foot, and mouth disease, anterior mouth, hands, and feet. True story, I was, some of you may have heard this if you listen to the tapes, but sorry about that. But many years ago, I worked with a third-year medical student on her very first clinical rotation. And I was working with her down on our pediatric ED. And we saw a kid with rash. And I said, okay, why don't you go, let me know what you think. She went and looked at the patient, came back and was presenting and was kind of explaining her differential diagnosis. And this is early third-year medical school when you're still trying to we remember what it was like. You're still trying to piece it all together, right? And so she's telling me her reasoning about the rash and what she thinks it is or what it isn't. She goes, well, I don't think this one's hand, foot, and mouth disease. And I said, okay, great. Why do you think that? She goes, well, it doesn't involve the hands, and it doesn't involve the feet, and it doesn't involve the mouth. And I said, okay, you're right. Then it's probably not hand, foot, and mouth disease if it doesn't involve any of that stuff, right? Anyway, it was cute. We were all there once. Okay, so anterior mouth, hands, and feet, all right? And basically, you want to just do symptomatic therapy. This is when the kids can have all the popsicles and ice cream and whatever they want, right? 'Cause you just want to keep them well hydrated. Some people use viscous lidocaine or things like that, but you got to be careful with that because it can get absorbed and they can seize, all right? So here we got young kid, had some fever, things like that, and it's got these painful vesicles on their tongue. It's hard for me to see if there's any on the lip, but I definitely see them on the tongue there. All right, see them? Hang on. I see that. I see that. Is there anything on the lip? I'm not seeing it, at least from up here. But you got some anterior things on their mouth. So I say, oh, let's look at this kid's hands and feet. Okay, the child has grown a little bit in the time that I looked at their hand and feet, all right? But here's their hands, and you can see they've got these kind of gray vesicles and some red vesicles, right? Kind of gray, those ones in the center, and red, that sort of thing, right? So that's their hand, and I say, okay, well, let me look at this kid's feet, too. Yep, I see something on the feet. It's a little more subtle, but that's where is it? Right there. See that? That's the gray vesicle. See that one there? All right, some gray, and there's a couple of them. Something up there, something down there. It's subtle. But that's what I mean by the gray look, but they can be gray and they can be red. So that's Coxsackie virus with hand, foot, and mouth disease. Anterior mouth, hands, and feet. Herp angina, I hate the name of this. Has nothing to do with herpes. I don't know. I'm sure there's a reason why it's called this. I've never bothered to look it up, but it annoys me. This is also Coxsackie virus, right? They also get really painful lesions in the mouth, but this is the back of the mouth, not the front. This is the back of the throat and no hands and feet, all right? So that's Coxsackie virus. Spread among kids real easily. Posterior pharynx. Anterior mouth is spared. Cone down view into the back of the mouth. You can see those really painful things on the soft palate, on the uvula hanging down there. That's still Coxsackie, but this one's herp angina. No hands, no feet. HSP, let's do this one. HSP, this is pretty common. I'm just curious. How many have seen HSP? Yeah, look at that. A lot of people have seen this. So this is something you're going to see. Most common vasculitis affecting kids. So if it's a kid and they got vasculitis, meaning palpable purpura, you're probably going to be safe going with HSP as the most likely cause at least, right? So what is this? This is like an autoimmune vasculitis. They start with something. Sometimes we don't know what the something was, but there could be a strep infection or a GI infection like Salmonella or Shigella or something like that they had. And now they get this kind of autoimmune reaction to it, this vasculitis that they get. And this vasculitis kind of will appear in multiple different ways. Well, since we're doing derm, let's start with the skin. So the vasculitis on the skin, what's the lesion going to be? Palpable purpura, right? So they have palpable purpura on their skin, but classically it's on the buttocks and like lower legs. And if it's on the arm, it's like the lower arms. It's like a gravity distribution is the way I think about it. Buttocks, legs, lower arms, that sort of thing. So they've got palpable purpura on a gravity buttocks sort of distribution, okay? They have these same skin lesions occurring in the GI tract. So guess what that's going to do? That gives you bleeding. So they may have heme-positive stools. They could have GI bleeding. And in fact, if one of those lesions gets big enough in the GI tract, it can serve as a lead point for an intussusception. So they can get intussusception. So they can get GI bleeding, they can get belly pain because they got these same things going on in their intestines, and they can get really bad belly pain if they got an intussusception like that one. They have an intussusception, right? I can't say it. Intussusception. They have an intussusception, right? So severe intermittent abdominal pain, think about intussusception in those patients. So they got the lesions in the skin, they got the lesions in the gut causing belly pain and GI bleeding, and they got the same lesions going on in their kidneys, all right, causing hematuria, all right? So they got hematuria, heme-positive stools, they can have these things, and they got the rash on the skin. That's kind of where it's going. This is not a platelet problem. There's no thrombocytopenia. This is an immune vasculitis, right? This isn't a platelet issue. So the platelet count is normal. And they can get, like I talked about, arthritis, they can get glomerulonephritis, hematuria, GI bleeding, intussusception. They may get followed up, basically they're generally discharged. They may get a renal consult at some point, but they tend to do okay. All right, let's look at this slide. When I look at this slide, I think vasculitis, because I see purpura, right? I see, like, look at that. That looks like purpura. This looks like purpura. It's palpable, and it looks like it's going to be palpable. This has that funny little yellow look to it. I don't know if you've ever noticed this, but a lot of vasculitis will have that little bit of yellow look to it as well. So I see this and I think vasculitis. I don't know it's HSP. It could be any vasculitis because I can't tell the distribution or anything else. But that looks like HSP to me. Excuse me, that looks like vasculitis to me. Again, palpable purpura, right? That looks bumpy. Palpable purpura is vasculitis. I still don't know which HSP other than what it says on the top of the slide. Now I'm thinking HSP because of the distribution of it, okay? Buttocks, legs, lower arms. Now I did tell you it's usually in kids. This is a very advanced child who is married off at an early age with the wedding band going on there, okay? So it's not always kids, but if this was a kid, let's just shrink this a little more. You got a kid and you got the palpable purpura on the buttocks. Now I'm thinking HSP. And now I'm thinking, oh, gee, are they GI bleeding? And what's their renal function? Are they having hematuria and things like that too? All right, so that's HSP. Let's talk about Kawasaki disease. How many of you have seen this? Yeah, yep. So good bunch. It's not like really, really common, but you'll definitely see this if you're practicing long enough, right? Kawasaki's disease. This is a vasculitis in kids, young kids. You get a 4-year-old Asian male who comes in you with a fever. Now, this is more what you're thinking about. And the fever's been going on for a week. What's going on with that, right? So classically, it's an acute febrile illness, ages 2 to 5. Asian male would be classic. If you're going to write a board exam STEM question, would be classic for it. It's a vasculitis that has a preference for the coronary arteries, the arteries of the heart, the coronary arteries. And what they develop are coronary artery aneurysms. That can't be good, right? So that's what we're trying to prevent with our treatment is coronary artery aneurysms. Okay. No one knows what causes it. If you remember, there are criteria for making the diagnosis of Kawasaki's disorder. You have to have a fever for 5 days. So 1, 2, 3, 4, 5 days of fever, plus you've got at least 4 off of this list here. 4 off of this list here. And unfortunately, you just got to remember this stuff. The list is conjunctival injection. So it looks like conjunctivitis, right? Like bilateral conjunctival injection. Next option would be oral things, oral changes. So strawberry tongue or fissured or cracked lips. So anything in the mouth there. So oral sort of changes. The third would be swelling, like extremity changes. So swelling or peeling of your fingers and toes, any of those. So extremity sort of changes. The fourth would be a rash. Not really that specific. It's a red rash. It may be on your palms and soles as well. So red rash. And the final one is anterior cervical nodes that are at least 1.5 centimeters big. So not just a little shoddy adenopathy, they got to have at least 1.5 centimeter anterior cervical nodes. So if you've got 5 days of fever and you got 4 off of this 5 options on the list here, you have Kawasaki disease, okay? You've diagnosed it. It's inflammatory, so your white count's up, your SED rates are up, your platelets are up, all those sort of things as well. The thing we're trying to prevent are the coronary artery aneurysms, and the way we treat these patients is we give them an aspirin, and they give them intravenous immunoglobulin, IVIG, right? So aspirin and IVIG. So they're admitted, they get aspirin, and they get IVIG. Now, I have to ask you a question. Let's just put on our logical brains here. If you saw a patient who had 4 days of fever, not 5, and they got like all the things on this list here, are you just going to like send them home and say, go follow up in clinic? Yep, all right. Somebody's bold, all right? I do not want to be your medical malpractice carrier. I hate to tell you this, all right? Because There's this thing called incomplete Kawasaki's, right? Maybe tomorrow they'll have their 5th day of fever and they got Kawasaki syndrome, right? Maybe that's what's going on. So there's this thing called incomplete Kawasaki's. So just because they don't miss every single one of their criteria, don't send them home. And I know you were joking. Don't send them home. You gotta still admit them and they get worked up. So if they've had, say 5 days of fever, but they only got 3 on this list, they don't got 4. Or if they've got a bunch on this list, but they haven't had the full 5 days of fever, they still get admitted to the hospital. They get worked up for incomplete Kawasaki's. And what they'll do is they'll do lab tests. They'll look for their SED rate and white count and things like that. They'll probably do an echo as well, looking for any of the coronary artery aneurysms. And they'll make a decision about whether they're going to empirically treat them or not. And they oftentimes will, right? I'll give them an aspirin and the ED because I want at least done my part. And they can decide about the IVIG upstairs. Fair enough? Okay. All right, Kawasaki's disease. All right. So Kawasaki's disease, we're looking at some pictures now. 5 days of fever, and I'm going to start making some stuff up, all right? 5 days of fever, but you can see strawberry tongue, cracked lips, that's actually real. Now here's where I'm making it up. And imagine they have conjunctivitis going on under there, and imagine they have anterior cervical nodes going on there, and imagine if their extremities down here at the floor has got some, peeling and cracking, things like that, all right? You got it. That's Kawasaki's. And there's the extremities, right? Peeling of the extremities, swelling of the digits, peeling, swelling, all that going on. That's Kawasaki's. Okay, impetigo, another very common childhood rash, right? This is a very superficial infection. This is not like cellulitis. This is a superficial infection by strep or staph, superficial epidermis. Young kids, preschool kids, they give it to each other all the time. Red moist vesicles, I'll show you what I mean on a picture about that. And honey-crusted lesions, right? The honey-colored crust is classic for impetigo. Because you can have strep, you can get a post-strep glomerulonephritis just like you can with strep throat. But we don't see that often, okay? It's just a factoid. But it's a superficial infection of the skin. That's impetigo. You can treat it with dicloxacillin or cephalosporins, first-generation cephalosporins. It's usually not MRSA, right? So you can use oral. Actually, if it's mild, if it's just really local, you can just use topical. You can use mupirocin, right, Bactroban. You can just use topical mupirocin if it's small. If it's more extensive, you can use oral, usual stuff like diclox or cephalosporin. If for some reason you are particularly concerned about MRSA, fine, you can broaden out and cover MRSA sort of things. The world's best photo of honey-colored crust, right here, all right? That's it. Face right into the honey jar. That's honey-colored crust, all right? That's impetigo. This is bullous impetigo. So you got some honey-colored crust, right? So that makes you think it's impetigo. But sometimes you won't even see the honey-colored crust. You'll just see lesions that look like this. That just red kind of vesicle. I think there's kind of another one, little honey, but red moist vesicles. You see a bunch of those things. Don't be fooled. That's impetigo too. So you get these red moist vesicles. You look for honey-colored crust. Pretty straightforward. All right, I actually took these photos, believe it or not, and I'm like the world's worst photographer. But this was a young boy that I saw who was getting out of a swimming pool, and he like scratched his chest and scraped his shoulder getting out of the swimming pool. I can't remember how long, but it was like a day or two later, he came into the emergency department with this. And he had an infection, but it wasn't like all red, warm, and deep. It was like superficial, and he was like dripping with honey. It was essentially the equivalent of an impetigo. Put him on some antibiotics. Same kid. This was what his shoulder looked like. Just a bunch of like honey-colored crust going on there. Really interesting. Not where you usually see it. Okay. Next thing I want to cover for you all is rubella versus rubeola, the German measles versus the real measles. And it's important for our practice, and you could really write some good exam questions. So let's just kind of remember this, and I'll hopefully try to give you the easy points to try to remember this stuff. So let's start with the German measles, okay? German measles, as you know, rubella, it's a viral infection, and these patients are febrile, right? They got fever, sore throat, headache, all that usual stuff. And then they start with the rash, which are these kind of pinkish, reddish, brownish little dots, little macules all over the face. It starts on the face, and then it works its way down to the rest of the body, works its way down to the torso, that sort of thing, head to feet, extremities as well. Now, the thing about the German measles is it's also called the 3-day measles, and that's the way I like to think about it. Rubella is a 3-day measles, because it reminds me that it's milder. It's 3 days. It's a 3-day measles. It's a wimpier form of measles, okay? And usually the rash is on your face, right, the first day, And by day 2, it's already moving down and getting to your trunk and getting to your extremities and that sort of thing. So it moves through you pretty quickly. It's a 3-day measles. You also may have some adenopathy, some posterior, like cervical or auricular adenopathy. So they got the fever, they got the dots all over the face, maybe a little posterior adenopathy, but it kind of moves through them pretty quickly and they tend to do okay. That's rubella or the German measles. Now, rubella is the R in torches. So rubella is not good as a congenital infection for a fetus. So that's why all pregnant women are screened for rubella to make sure that they're rubella immune, right? And if they're not immune, then you got to really watch out for the German measles. That would be bad. Okay. So here's somebody who had some fever, had maybe some adenopathy, had the rash on their face, and by day 2, it's already down there on their body. And you see what it looks like. Red, brownish, bunch of little dots all over the place. That's rubella. And they tend to do okay. Here it's a little more subtle, but there's a little bit of red rash, a little bit of red dots all over the patient, right? If we blow it up a little bit, you see a bunch of little red dots there all over the face. Okay, maybe there's some posterior adenopathy too. I made that up. It's not on the slide. Okay, but that's rubella, the German measles, the 3-day measles. It's not that bad unless you're a fetus. Rubeola, on the other hand, is the real measles. This is actual measles. This is what we're getting all these outbreaks around the country in little pockets where there's not adequate immunization of the population, like where I live up in Marin County, California, okay? Outbreaks and things like that going on where folks do not want to take the vaccine. So, measles, what do we need to know about measles? Fever and the 3 C's, cough, conjunctivitis, coryza, all right? Coryza meaning runny nose. So it's a kid maybe, or it could be an adult of course, fever, cough, conjunctivitis, coryza, the 3 C's. And then they get the Koplik spots. Remember the Koplik spots? These are these little white kind of grains of salt, grains of sand or salt inside the mouth on the buccal mucosa that you see. These little white kind of grains of salt there on the buccal mucosa there that precedes the rest of the rash. So you got the fever, you got the 3 C's going on, you got these little Koplik spots, and then you develop the rash of measles, which is the same sort of rash, a bunch of red, brownish spots all over the face that move their way down to the body. But this is not the 3-day measles, this is the measles. So this is lasting longer, the rash is on the face longer, it's slower progression, and these patients can definitely get sicker. And the biggest complication that we worry about is encephalitis. Really sad to see these patients who are otherwise healthy develop measles and end up with encephalitis and brain damage. Not good, okay? So let's take a look. Okay, it's kind of subtle here on this slide. It's hard to see, but there's a little bit of let me see if I can blow it up. A little bit of brown spots all over on this patient here. A little kind of brownish spots on this patient, all right? Subtle appearance, but this is measles. This patient, they have a conjunctivitis. That's easy to see. And this patient, the only normal skin that's left is this little bit of, little bits of white up here, but a bunch of that, it's a bunch of red dots, and they're all over, and they've started to coalesce. So this is a sick patient with measles. Not happy. All right, this is not the world's best slide for it, I got to be honest with you. This looks like any old red rash to me, but in the right setting, I guess it's measles. Here's our Koplik spots. Let's see if I can find one. Okay, I think I see a little white spot there, right? Little white spot, one there, one there. These are these little white spots, okay? And by the way, if you get to the board exam and they're showing you somebody holding their mouth open like this, right? And you can't quite tell on the computer screen like what's going on, just go for measles. I mean, who else opens their mouth like this to show you the buccal mucosa, right? It's got to be measles. Okay. So we covered it now. We covered the German measles and we covered the real measles. German measles, 3-day, milder, goes through you okay. The real measles, bad, cough, conjunctivitis, coryza, Koplik spots, and they do sicker. They get sicker to get encephalitis potentially. Okay, let's do roseola now, another pediatric rash here. Roseola infantum. So how do these patients present? So this is a kid who, young kid, maybe under 2 years. This is a pretty young kid. It can be older, but younger kid, comes into your emergency department, high fever, okay? Maybe even presented with a simple febrile seizure, right? It's associated with human herpes virus 6. So they come in, fever, maybe a simple febrile seizure. You did your usual workup, which is not much of anything. Maybe check their urine, right? Give them some Tylenol. They have no rash. There's no rash. They look fine. They just got a fever or a simple febrile seizure. They go home, and then as they start to defervesce, Now the rash comes out, okay? So that's what happens with this one. So this is not like slapped cheek where you're febrile and you got slapped cheek. This is where you were febrile and you're defervescing and now you get this rash. And it's just a non-specific red rash all over the body, okay? And it's not the rash itself that you look at and so, oh, that's roseola. It's the timing. It was a little kid who had a fever or maybe had a simple febrile seizure. They started to defervesce and now they got these kind of like viral looking rash all over the body, okay? That's what roseola is, okay? Human herpes virus 6, simple febrile seizures, it's when you defervesce. That's pretty much it. Again, here's a kid, maybe they were febrile, maybe they had a febrile seizure, they defervesced, and they get this rash. It looks like all sorts of red, bumpy rashes we see, right, in a medicine that we never figure out. But that's what it is, that's roseola. Okay, lice, let's do lice. You got your head lice, your body lice, your pubic lice, all right? Head lice, itching on the scalp. Remember, you get the little eggs that are, the nits that are attached to the base of the hair, the shafts of the hair there. Body lice, itching all over the body. Those little nits, those little things are on the seam of your clothes, right? You're not going to see them attached to your hairs there. You see on the seam of the clothing. Pubic lice, which is crabs, intense itching down there, all right? It's sexually transmitted. Treatment of these lice things. You remember, you got to clean everything, right? So you get their sheets and their clothes and their whatever, and you wash it in hot water and you dry it in a hot dryer and all that sort of stuff, right? On the patient, you give them these over-the-counter things like these parethrins, these over-the-counter things that they, shampoo their heads and stuff like that with, right? So that's what you're usually treating it with. By the way, just a couple side hints here. When you're treating their clothing and stuff like that, right, you're putting it in hot stuff, it can ruin it. So I always think, like, what do you do with Fluffy the bunny? And I don't mean the real bunny. I mean like the stuffed bunny, Fluffy the bunny. You get Fluffy the bunny, and you don't want to put Fluffy the bunny into the washer and dryer, otherwise Fluffy is not going to be fluffy anymore, right? So the other alternative is you can just take things and stick it into a plastic bag and close it up, And if you did it for 2 weeks, you're totally safe, but you can even do it for less, probably, 72 hours a week, things like that. I leave it down for a while because I don't want to mess with it. But basically, Fluffy the bunny goes on vacation, okay, for a little while, and then Fluffy the bunny comes back and is still fluffy, so you can do that as well. There's actually a lot of resistance now to the first line over-the-counter stuff with lice. You've seen this before in kids, right? They got head lice, you pour the stuff on, and the lice are just like, ha ha ha, I'm swimming in the pool now. I'm happy. I'm resistant to this. The heck with you, right? So there are other agents you can use. One of them is called malathion. Anybody used this before? Yeah, a few of these you've used this. So malathion is an agent that you can use using the scalp. Same sort of thing. It's a malathion lotion. What's really interesting is when you look at the bottle of malathion and it tells you the warnings, there's a big old warning that says, keep head away from open flames, okay? I'm totally telling you the truth. Keep head away from open flames. It's apparently really, really flammable, okay? By the way, that's just a general rule of thumb for parenting and growing up as well, right? Keep head away from open flames, so I'm just saying. Okay. Okay, so that's your lice. Let's look at it. There's a lice, itching. You got the little nit there, and you got to get those out with the comb, right, so they don't hatch. Okay, you remember that. Scabies. Ugh. The term the 7-year itch came from scabies. That's bad. That was a long misdiagnosis, right? So you know about scabies. It's this little mite that gets into your body wherever you have thin skin, like between your fingers and toes, gets in, crawls in, hangs out, eats, poops, and you develop over the next several weeks an allergic reaction, a hypersensitivity reaction to the feces of this mite, okay? And you start itching. That's just gross, right? And you're not just itching right where the bug is, you're itching all over because it's a hypersensitivity reaction. You're itching like crazy, all right? That's what it is. And remember, when you look at them, you're going to look for areas of thin skin, like around the elbows or in between the fingers and between the toes. And you see these little papules. They may be excoriated because they've been itching it. You may see a linear burrow if you're real lucky, that sort of thing. Treat with permethrin cream. You can also use oral ivermectin. Lindane lotion, that's pretty much out. We're not doing that anymore, especially in young kids. It can cause seizures. There is this thing called Norwegian scabies. Norwegian scabies is really bad scabies, all right? In a normal adult, you have maybe 6, 8 mites on you, something like that. In Norwegian scabies, guess how many you can have? I heard hundreds. We're in Vegas. Can we keep bidding up? Thousands. You can have over 1 million mites on a body. unbelievable. So these are patients who are immunocompromised or otherwise debilitated, and it's basically just really bad scabies. They call it Norwegian scabies, also called crusted scabies, okay? If I was from Norway, I'd be kind of pissed off, okay? I'd be going with like crusted scabies is what I want to be calling it here. And again, you actually treat it the same. You just have to do it, you know, the lotion and stuff over and over and over to keep like decreasing the load of scabies. So here you are, itching this stuff in between the fingers. That's bad. That's scabies. Ugh, that's the mite. If you put a drop of oil and you got a microscope, you can see it. Itching between the fingers, okay? That's scabies. Again, itching there. By the way, in infants, they don't just get it between their little infant fingers and toes. They can get it like all over their body, thin skin all over, right? Okay, scarlet fever. Let's do this quickly. This is strep throat plus some other stuff. They got strep throat and they got the sandpaper rash on the body that spares around the mouth. You get the strawberry tongue. You get the Postia's lines, which are little like miniature petechiae lined up where you've got creases. So you've been doing this and you got a little crease in the antecubital fossa. And then remember the rash will then peel as well. So you got the sandpaper rash that peels. Diagnosis, throat swab. It's basically strep throat. So here's the kid, had strep throat. They got strawberry tongue. They got a very fine sandpaper rash going on here. Now they're peeling. All right, they also aged. That's scarlet fever. Peeling the toes. Chicken pox. Varicella zoster virus, you know about this. We used to get it all as kids. You'd come over to your neighbor's house when it was convenient, right, for your parent for you to get chicken pox, right? And your neighbor had chicken pox. They'd say, hey, why don't you go play with Johnny today, all right? You're going to have a really fun time, all right? Good time for me to take off work. You get your chicken pox. But now, of course, we have vaccine. Chicken pox, you remember the lesions come out in crops. They start as little macules that develop papules, that develop vesicles. Classically, a dewdrop on a rose petal. Beautiful, clear vesicle surrounded by erythema. Then those pop and crust over. And when everything's crusted over, all of them, you're not contagious anymore, right? But they come out in crops. Some papules, some vesicles, some crust. Any patient you see with chickenpox should have a bunch of different stages. And I always say it, but I'm going to say it again. What do you think of when they're all the same stages of the vesicles? Smallpox, and what do? Run. Thank you for those listening to the tape. Very good. Outstanding. Okay. Call 911. I don't know. Call CDC. Okay. Complications of varicella are more common in adults. Varicella pneumonia is probably the biggest one that I want you to know about. What about preventing varicella? There's a vaccine that you can use, right, of course. And what about if you get exposed to chicken pox? What do we do for that? Well, first of all, make sure that you haven't already had it, because a lot of people, even though they think they haven't had it, they have. So check your varicella titers. But if you have been exposed to it and you are not immune, they can use VZIG, varicella immune globulin, varicella zoster immune globulin, give you the antibodies to try to prevent it. Certainly, if you're a pregnant woman and you've never had it and you're exposed, you're going to get the immune globulin. If you're immunocompromised, you're going to get the immune globulin. If you're a normal, healthy adult, they may not give you the immune globulin. They may just say, good luck, get chicken pox, take your acyclovir when you get it, end of story. Pictures, unhappy kid with chicken pox. Crusted, vesicle, papule, various stages. Adult, chicken pox, various stages. Dewdrop on a rose petal, the beautiful classic vesicle that you get with chicken pox. Different stages. Adult with different stages. Okay, this is just a summary slide, summarizes the 6 diseases we talked about. Measles, the real measles, it's bad. Fever, the 3 C's. Koplik spots, rash moving its way down. Chicken pox, we just covered. German measles is the 3-day measles. It's wimpier measles. 1 day on the face and it starts to move through pretty quickly. Scarlet fever is, strep throat plus all the other stuff, the rash, the strawberry tongue. Erythema infectiosum is 5th disease. 5 fingers on a hand, slap cheeks. Roseola is when they had the simple febrile seizure or the fever, they defervesce, and then they get their rash. Last thing to cover, and I'm going to do it real quickly because we've talked about this a little bit already in the course, is occupational exposures. Remember, with hepatitis B, surface antigen means the person can infect you. Surface antibody means you are protected if you have enough of it, okay? Your risk of a needle stick if somebody's infected is about 6 to 30%. It's a broad range. And the answer is it's really 6% if their E antigen is negative and 30% if their E antigen is positive. Because E antigen means you've got lots of particles, all right? Vaccine is very safe for Hep B, 0, 1, and 6 months. You then check the titer. If you're over 10, you're protected for life for the most part. If you're not over 10, they give it to you again, 0, 1, 6 months. If you're over 10, you're protected. If you're not, you're a non-responder. It's like being non-compliant. We have to do special things, okay? Immune globulin, you can use that for people who are totally bare, have no immunity, and basically have been exposed to hepatitis B. We can give them immune globulin to help prevent it. Has to be given within a week of exposure. So if you get a hepatitis B exposure, the source, you test for the surface antigen to see if they're contagious. The person who got exposed, you check their antibody level, unless you already knew it was over 10, in which case you don't need to do anything. What do you do when somebody's exposed? There's a bunch of different scenarios here. There are only 2 that I think are testable for the boards. One is somebody's completely unvaccinated, nothing, they've never had hepatitis B, and they get exposed to it. That person gets immune globulin, and you start the vaccine. Pretty simple. The other scenario I think is fair for the exam is somebody who is known to have a titer over 10. It's been there, it's done it before. You do nothing for Hep B for that person because they're already immune. Hep C. It can be transmitted through the skin, as we all know, through needle sticks. Sexual transmission is not very common. There is no post-exposure prophylaxis for hepatitis C. There's no vaccine, there's no immune globulin, so it's just monitoring and seeing how they do. There's no post-exposure prophylaxis for Hep C. HIV. Absolutely, there is post-exposure prophylaxis for HIV. If you get a needle stick from someone's HIV positive, your risk of getting it is about 1 in 300, okay? It's about 0.3% is the way of thinking about it, okay? Not every stick is as bad as every other stick. There are little ones, like a solid suture needle, and there are big bad ones, like hollow bore, deep injury. You were doing a blood gas. The needle is dripping with blood. Those are obviously higher risk injuries. Post-exposure prophylaxis is recommended when you have an HIV positive exposure. You test the source, you test the healthcare worker, you start your meds as soon as possible. Certainly within 72 hours, but get it on board as quickly as possible, within 1 or 2 hours if you can. As you know, there are multi-drug protocols because of lots of resistance, combination agents that are used, the side effects are bad, it's 4 weeks of treatment. Unless you do this a lot, I encourage you to phone a friend, call your consultant, or you can use the post-exposure prophylaxis hotline, which is here on your slides as well. But phone a friend, because sometimes you use complicated regimens. You've put up with all of us for a long time. Thank you so much for being here. It's been great to meet many of you. Travel safe.